We are live, sir. Please start.
Yeah, good evening to all of you, and thank you all for joining for this live webinar on the advances in breast cancer. That we'll be covering actually two important updates that has happened, that is in ESMO and the San Antonio 2025, and this is the third edition, and this is a pure academic endeavor, and there would be no conflict of interest because we do not have any company support for these meetings. So there are few ground rules. So there'll be on the day one we'll be doing three panels on the three different subtypes of early breast cancer. And definitely one of the talk will be on statistics, and that we'll do after the first panel, and we'll have Dr. Sendil for that. But before that, without much of delay, I would like to invite my first moderator, and he's a dear friend, and who would be doing the panel on uh, early breast cancer hormone positive, and it will be moderated by Dr. Prabhat. He is the professor, Department Medical Oncology, Tata Memorial. He has a very good panel of experts, and it is Dr. Chetan, a very dear friend. We go back quite some years now. He's a senior consultant from Dinanath Mangeshkar, Pune. We have Chandrakant. I think he has joined. Can someone confirm? And he's a senior medical oncologist from
I'm joined, sir.
Kolkata.
I'm joined. I'm there.
Hi, Chandra. Yeah, then we have Soumya, again a dear friend and junior from my alma mater, and that's Katak, and he's practicing in Bhubaneswar right now. And one of my person, again very close to me, Bharat, and one of the person who's looks into trials quite a bit, Bharat from Hyderabad again. So, Prabhat, it's all yours now.
Thank you, sir. I would like to share my screen.
Yeah, please support team. Yes, Prabhat.
I welcome my panelists, Dr. Chetan Deshmukh, sir, Dr. Bharat Vaswani, sir, Dr. Chandrakant, and Dr. Soumya Panda. Dr. Sahu, sir, has already given introduction for all of you all. So let's start without any further delay. So we know that scope for hormone positive breast cancer, now that NEJM publication came in 2017, that we are nowhere even in hormone positive breast cancer, only that we are delaying the time of relapse. At 20 years, one third of your patient are patients in T1 and node positive N4 to 9 will have disease back. Even node negative, 13% of patients will have disease back. So we definitely need to do something more, and that is why this area of is still of a interest even into 2025. And let's see what all trials have come in 25 to change our practice. Even grading of tumor does matter. That amount of time that a patient will relapse is less number of patients will relapse, but if it is a high grade tumor, obviously more number of patients will relapse. This was key point, and everybody of us are aware of this point, but I've kept so that I can start my discussion. So I will start my discussion based on three cases, then some cross trial lessons, that what should we assume from based on the early results that we have of the trials shown in 2025, and some brainstorming just as a researcher, that I thought one trial I found important will be my last as an interactive wrap up. So starting with first case, low risk dilemma. A 45 years old female who was postmenopausal by this age itself, presented with an early breast cancer, was often operated in view of small tumor size. It came out to be 1.8 centimeter tumor, PT1C, node negative. ERPR was strongly positive, 90%, 90%, and HER2 was negative, with Ki67 of only 8%. So, what would my panelists do next for such patients? She's postmenopausal at 45 itself. Does that matter to you? Or postmenopausal is postmenopausal? Dr. Chetan, sir?
Postmenopausal lady is postmenopausal. Whether it is she has attained menopause at the age of 45 or not is not important for me. What is more
No.
interesting is with the KI of 8%, her
No, I
two
will come.
zero.
I will move forward. Yeah, leave aside the second part. So with KI 67 of 8%, what would you do next?
Normally, with a Ki of 8% postmenopausal, I wouldn't have offered her oncotype DX, but she's already done. Somebody has done oncotype DX, and the
Yes,
risk
sir.
was sort of an intermediate type. So, well, I'll have to act on it.
So it is just 16. So what will you do?
Well, if I can see that on your slide you mentioned she's declined chemotherapy, then obviously
But would you advise or would you
we have
not?
been
That
left
it
with
is
no choice
16,
but
then
to
you
offer
are.
her endocrine therapy. But I would definitely look at her other parameters, comorbidities, and all other things, and probably just continue my endocrine therapy, standard endocrine therapy. I won't add on anything.
Okay. Nothing, no chemotherapy? Or will you advise chemotherapy at least?
She's already declined chemotherapy. With
Will
a
you
Ki of
insist?
8%, the benefit of chemotherapy with the 16 oncotype DX is about 1.52%. I would probably not push for chemotherapy.
So will you neglect 1.5 to 2% benefit that you also feel would have been there, considering that she has done oncotype DX?
Yes, there is a benefit. I agree that there will be a small benefit, but if the patient has declined chemotherapy, then, well, we cannot do anything. Otherwise, for a lady who is less than 50, I would preferentially offer some kind of chemotherapy at least.
Okay. So initially you said 45, postmenopausal is postmenopausal, but now you are adding age also again back to the discussion.
Yeah, because standard the EBCTCG had shown that less than 50 and more than 50. 50 is a cutoff point, and less than 50 there is some benefit of chemotherapy, premenopausal, postmenopausal notwithstanding.
Any other panelist would differ or would want to give chemo, but if patient says no, then are okay with it?
Sir, I'll try to make, sir, basically in a Taylor X study, when you see, even in less than 25, the benefit was there where the score was between 21 to 25 in a premenopausal. So I beg to differ. I would not have offered chemotherapy anyway. Probably if you would have written 21 oncotype DX, I would have given a 4 to 6 cycles of docetaxel. 16, no. Even Taylor X was clear that the benefit, if you say less than 25, was from 21 to 25, not at 60. So I beg to differ, no chemo, sir.
Maybe in postmenopausal, even I would agree. Any other panelist has any other comment? Considering postmenopausal with a low risk? And that I know that Ki67 was also 8%. Dr. Chandrakant?
Hi, Dr. Prabhat. I think, as you very correctly said, I would not offer chemo for him, chemo for her, only endocrine therapy and no CDK4 inhibitor and no oral SAT.
So you have added, come to the second point also. Not even CDK4/6. No chemotherapy, no CDK4/6 inhibitor.
Only
No,
aromatase inhibitor.
only aromatase inhibitor. And for how long?
5 years.
Yeah, so I will like to give chemotherapy, Dr. Prabhat, considering that it's a PT1C. So again, PT1C can be something like 1.1 to 1.9 centimeter.
Yes.
Probably would like to look into all the factors of the reports and then take a call. The grade is not mentioned here.
Ki67 was only 8% as per the local pathology report.
Yeah, but then grade can be also important in such cases. So, but
Bhai, the oncotype DX is saying no benefit. Why you want to give?
yeah, oncotype DX is 16 actually.
If she-
Sir, the role of oncotype DX is to tell us whether we should add a chemo or not. And if you don't believe in oncotype DX, then I don't
I
think there is
do.
something which is better at present now than oncotype DX with so much of a robust data. And 16 is supposed to be a low score, sir. It relapsed, that is absolutely. But at the end of the day, this is why we do oncotype DX. Otherwise, there was no point in doing it when.
Then the oncotype DX and patient is declining chemotherapy, then it's a different thing.
So, as per high genomic risk analysis for lidERA trial, patient comes into high genomic risk score. So, should I go through the trial first, or I will go through? Then we can say whether anybody would like to increase this patient to, as Dr. Chandrakant wants to give only aromatase inhibitor. I would like to draw attention to the lidERA trial, which was presented in this SABCS, where patient even in node negative if they have high risk on genomic assay, or they were PT4 or Ki67 more or node positive, irrespective of menopausal status, and who had completed surgery and standard chemotherapy and other standard perioperative therapy, were randomized to standard of care ET versus giredestrant. And what they
Our patient doesn't, sir, our patient still doesn't fit here. Only thing is more than one, but it is not grade 3 and Ki67 is less than 20. So you should have either of the two with more than one. Our patient
if
don't
It
set.
is less than 25. It is less than 25, no? So this is
Sir,
a
our
rule.
score is less than 20 or grade and score. So grade 3, it is not there, it is not so. It is not in our patient, still is not in lidera trial also. Sir.
Correct, I agree.
Great. But so I started just with a very low risk patient. Now I will modify that if the oncotype DX was 23 for this patient and she was premenopausal, what would our panelist decision change?
With an
Yes, I would
oncotype
have
DX
given
of
chemo, sir.
23, then there is no question. For a premenopausal woman, it forms a high risk score.
Yes, sir.
It goes in for chemotherapy.
Yes.
Maybe we had to ask clearly whether the patient was really postmenopausal. I made age of 45 just for the discussion sake of oncotypes of 16. So everything changes as the pre and post changes and oncotype DX score. Irrespective of oncotype DX, if it was premenopausal, would you have done oncotype DX for this patient? Just premenopausal patient with a 1.8 centimeter ERPR positive and Ki67 of 8%.
The number of people in the Taylor RX study who were less than 50 are very, very small. So, that is.
Whom do you send? What is your threshold for size and or any other thing that you see while sending a patient for oncotype DX?
Preferentially, since we do it very infrequently, I would preferentially use it for women above the age of 50 or confirmed postmenopausal.
Dr. Chandrakant?
So premenopausal T2 N0. I can send for oncotype DX.
Pre also?
Yeah, premenopausal N0 I can send.
Anybody else? Dr. Vaswani sir?
All node negative, sir, I send it for on and T1, T2. All node negative, irrespective of menopausal status, I send. Any node positive, pre-menopausal, no need, you have to give chemo. And then otherwise, even up to 3 nodes, if it is post-menopausal, I send it for oncotype DX as per as the guidelines and as per as the trial registration, sir.
So node negative premenopausal and node positive up to 3 nodes in postmenopausal.
Yes, sir. That is very common.
Okay. Suppose that this patient was in high risk as per genomic score and was node negative. So this patient fits into N0, the inclusion criteria, and roughly 1/4 of the patients, 1/5 of the patients were N0, even in this high risk, in this cohort of all comers. And there was roughly 2% benefit at 3 years, what the study has been presented at SABCS this year. Are my panelists impressed by this 2 to 3% difference in IDFS at 3 years? I don't think anybody is impressed. Otherwise,
Sir, definitely,
Yes.
sir. The absolute benefit is 2.5% with the reduction in hazard ratio by 30%. So probably absolute gain, if you compare your adjuvant tamoxifen versus this AI, this quantum of benefit is only 3% only in that case. So this is absolutely, and when you compare this with any of the high risk even in Monarch and Natal, it is early, sir. If you see, it is 2 years or 3 years, 2.5 years cut off. And all of us know that there is a carryover effect. So this difference should increase over a period of time. So I think this is probably the best, most impressive thing. For the first time, you are having a drug in an adjuvant setting whose quantum of benefit is the best at such a short interval. At present, adjuvant 2-3 years. Maybe at 5 years, this may increase as we have seen in other trials also. So I think this is very, very impressive. Practice changing, I cannot say, because cost availability in future, and again, I don't think so. We have seen the complete story. Complete story will come when you combine with Abima, as in metastatic setting, Ember, everything. So probably that would be a game changer maybe in future. But at present, 2.5 absolute with 30% reduction in the risk of IDFS is impressive data. In such a short follow-up period, that is more important.
Such a short follow-up period. But just now, Dr. Chetan was ready to forego chemotherapy, even when he knew that benefit is there for 1.5 to 2%. So, Dr. Chetan, will you switch or will you let go this trial also?
I think Chetan is rejoining. That's what he told. He just lost the contact. He'll just rejoin.
Any other Dr. Soumya?
One of the panelists can take it. Yeah.
So,
Dr. Soumya?
yeah. So, Dr. Prabhat, so the problem with this trial is that the CDK4/6 is not there. So we don't know right now. So it is kind of a standard of care that in high-risk patients will give CDK4/6 plus aromatase inhibitor or a hormone therapy. But in this trial, there is no CDK4/6 inhibitor. So that is one of the major setbacks. So this is one of the oral options if we are not considering for a CDK4/6 inhibitor. So the combination of the efficacy of giredestrant plus a CDK4/6 inhibitor. Right now, it is one of the oral options, but it is little bit back of time. So CDK4/6 inhibitor was not there. That's the problem.
Will you combine CDK? So you are in favor if patient doesn't want CDK4/6 inhibitor, then you will give giredestrant to the patient?
So right now it is very early stage or means early time. So at the 2 years, if you look at the hazard ratio, so yes, it is comparable with other Monarch data or say with Natalie data. But whether it is impacting OS or not, so that part we don't know.
Great. So that is why I will compare the cross trial. So too early to say what will happen. But one point to note is some patients receive only tamoxifen, now not even OFS. When we know that even OFS can be 0.9% to 2% benefit in such patients. So maybe if all patients would have received OFS, the difference would have come down. What we are seeing at present. Even good point is even in node negative, there is seems to benefit of giving giredestrant early. Very good point was the arthralgia, which we are worried that if we give more potent anti-estrogen would be there, was less compared to what AI arm had, and no significant increase in grade 3 for toxicities. But however, I have my concern considering the mechanism of action of giredestrant. Giredestrant only degrades estrogen receptor, and that is how it is more powerful in patients who have ESR1 mutation. And in metastatic studies, we have seen that it does not make a difference if patient does not have ESR1 mutation. So whether really over a period of time, the benefit which persisted, the 2% patient who are benefiting right now were early ESR1 mutated is maybe the reason, and whether over a period of time this difference will be maintained is to be seen about, and then only I will change my practice. And what even my panelists are trying to say that it is too early to say, but whether it will be sustained and carry over effect over and above AI, even AI have carryover effect. So whether there will be over and above AI will have to be seen. Is my doubt concerned that there is nothing additional that we are doing. We are only saving those some few patients who have ESR1 mutation, and that is why I would be more interested in this trial, treat ctDNA, where if patients have ctDNA relapse, there you are changing to elacestrant versus continuing ET even before they are actually relapsed. Just 220 patients study would give us more idea compared to all this ongoing 4,000 patients study will give us. And the year you can select your patients more appropriately rather than the other trials which are ongoing. But some trials are trying to select patients after 2 to 5 years of prior ET. This logic I didn't understand. Any idea why it was such? Even I am one of the PI of such studies. Any idea why after 2 years of prior ET are they trying to segregate patients and take into the third? Dr. Chetan, you would be PI of one of the trials.
Yes, I was PI on Monarchy, but then there the endocrine therapy and Abima was given together. So this was probably they want to select out better patients. After 2 years of maybe your early ESR1 PIK3s will probably progress.
So they will not be eligible. They are including patient between 2 to 5 years of prior ET.
Yeah, so the ESR1 actually starts coming up after 24 months, around 24, 28 months.
Yes.
So you are giving CDK4/6 for the first 2 years.
Yeah,
So you are giving all the best things. CDK4, you are trying to combine all your players for the treatment. So probably the
It is
impact would have been.
maybe sequencing
I
it, yeah.
think Dr. Soumya's answer is up to the mark that ESR1 comes approx 24 months. That is why secondary resistance is what we called in adjuvant therapy. And that is why they want to select patients who were now about to relapse. So they will have early suppression of their DFS curves, is what I believe, I feel. And maybe giredestrant will not have much value in front of all these trials of 2 to 5 years or selected DNA relapse, ctDNA relapse patients. Now, moving on to a high risk patient, a 32 years old, premenopausal, high risk in terms of age, premenopausal, even nodal status shared N3 disease, high proliferative KI 67, 45%, completed adjuvant chemotherapy. Obviously, because of high risk relapse, OFS was also given and patient was given anastrozole. So, what else will you offer such patient? Giredestrant or a combination of CDK4/6 inhibitor? Considering present data. Anyone?
Would offer CDK4/6.
Any doubt that it also has only 4-5% or only 1.8% OS benefit till now, sir?
Yes, but right now that seems to be the best bet. You're looking at an N2, N3, N2 disease. Sorry, N3.
Sir,
Agreed.
rather than looking at overall survival, we should look into IDFS, which is 6.5%. OS
Which is
probably again over a period of time, we might have further improvement. What is more important is there was some degree of cost crossover also. In spite of that, we have a statistically significant improvement, although it is 1.5 to 1.7. But the other parameters like IDFS, DRDFS, so everything is quite good. 6.5 to 7% is an impressive data. And we know that 25%, so high risk patient will relapse. So anyway, with the GnRH analog, because he's a premenopausal. So rather than OS, other parameters are also important. So we have to look into a broader pictures. So I think everybody should, only thing is which one you choose, that is always a debatable.
so starting from you, sir, which one will you choose? Do you choose normally? Or
Sir,
based
I
on
choose, if it is N2 onwards, I choose abemaciclib. The reason is lesser duration of treatment with a probably equal benefit, I think both of them, and probably you have a OS data also. So there is a long-term data, there is a OS data, there is a lesser duration of CDK4/6 to be given, and impressive data, I think so. So probably all the things are there, and it has a long data, 3-4 things, which makes us, so I, N2, no two dot, in N1, yes, there is some debate, but N2, I think, we all of us use abemaciclib because it is a longer data maybe. And you have a OS data also, which is not there.
and if patient only had 2 nodes positive after upfront surgery?
Again, the rule of 3, if it is more than 5 centimeter or grade 3 or KI67, we don't have a registration. But I think whenever the thing falls between Abema and Ribo, because of the OS data available, shorter duration, all the things I told, I think we prefer, or I prefer Abema over Ribo. Again, it is a personal choice, sir, and both of them are correct, sir.
Agreed. I think IDFS does matter here, as we saw in initial. That is why I put first slide that in after 20 years we will be aware what exactly did help in terms of OS, and it is too early to say 5, 6, 7 years. Really, IDFS should also matter at present. So, what is overall tolerance wise issue? Is abemaciclib easily tolerable with your patients, Dr. Chandrakant?
Right, Dr. Prabhat, I think if you can reduce the dose, that happens in around 40 to 50% patients, the discontinuation rate is something like 9%. So it's tolerable, and diarrhea is sort of less in our population. Fatigue is an issue. I think around half of them need dose reduction. Once you do that, I think people hang on that dose and do pretty well.
So, if this patient developed diarrhea after 18 months or continues to have diarrhea over a period of 18 months, you would have reduced the dose early on only.
Yeah. The whatever, if you look into the trial, the dose reductions have happened in the initial 2 to 3 months. After that, the dose has been stable. I think like half of them will need like 100 milligram twice daily. And even in those patients where the dose has been reduced, the efficacy is maintained.
Because of intolerance, do you change to ribociclib? Or you
Well,
really
we have the data in the metastatic setting as of now. But in adjuvant setting, the data is there. But yes, if he's absolutely intolerant, then yes, why not? We can change.
And for grade 2, even 4 diarrhea per day is actually grade 2. So I included here grade 2 diarrhea. Diarrhea
Right.
increase frequency 4 times a day that patient is passing will logically come into grade 2.
Right.
What will you do?
I think that's fine. I think the way is to anticipate, explain, and assess and reassure the patient. So patient will understand the diarrhea thing, and you can use prophylactic anti-motility agents. I think dose reduction works fairly well in these patients.
So this is based on the recent SABCS, where in recent ESMO, where final OS data for abemaciclib also came, adjuvant abemaciclib. We all know the trial design, and Dr. Vaswani has already said that 1 to 3 nodes were included in both the trials, and more than 4 is definitely abemaciclib at present a winner because of the OS data that has recently come in a recent ESMO, which is showing that at 7 years, patient has approximate 1.8% benefit more number of overall survival. And at IDFS, there is a carryover effect seen that even after stopping 2 years of abemaciclib, the difference between the IDFS curves this seems to be increasing, and now at 7 years, it has reached 6.5%. So it definitely seems impressive, at least till 7 years. And now that there is 1.8% OS benefit for which we do give chemotherapy for most of our patients. And Natali is just behind and less data, as Vaswani sir has already said. It is now shown at 5 years. Again here you can see that the curves are separating more and carryover effect is seen. And at 5 years, there is delta of 4.5%. Especially even in node negative patient, you need to do something extra, and maybe ribociclib is presently the key for that 2% benefit that our patients can offer. Why am I impressed more as compared to gidrastant with CDK4/6 inhibitor? Is because CDK4/6 inhibitor also calls senescence, and they are not just static. They have immune modulation, which also can lead to sidal effect and sidal effects by the mechanism per se, which is not in gidrastant. So I would personally favor CDK4/6 inhibitor in present scenario, considering we don't have a data of gidrastant plus CDK4/6 inhibitor combined. Do my panelists agree? Present given scenario, patient fits in both trial lidera or monarchy or ribociclib. What would be your present choice? Dr. Soumya?
Yeah, so for giredestrant, I'll wait. And between the monarchy and the ribociclib will probably in N0 population with the high risk features, and rest of the population I'll use abemaciclib.
Okay, so you agree with Dr. Vaswani at present. Dr. Chetan, any input why palbociclib failed? There were 2 trials done, both failed and could not show survival benefit.
Yeah, I believe there are a lot of, at least 20% of the patient population was T1, T2. And so that probably took away the shine of adding the additional CDK4/6.
So will we see a carryover effect, and suddenly after 10 years we will find that even it caused 5% OS benefit, or it is a flop drug? You are
No,
blaming the and not the drug.
No, I don't blame the drug. I think that the design, if it would have been in on the same lines as of Monarchy, probably it would have shown a decent survival benefit. There's nothing wrong with the drug. In fact, that amongst the three, it is one of the easiest drug to handle. So compliance issues will never come with palbociclib like you have with ribo or abema. And well, I don't think we'll ever get that trial that only T3 or N2 disease with palbociclib, but uh, probably down the line, we will probably come up with that data. It is extremely tempting for a lady who otherwise does not have access to ribo or abema because of cost issues, as an N2 N3 disease, young lady, barely in her 30s. It's extremely tempting to use it. As of now, we cannot use it for obvious reasons, but yes, it's very tempting.
Good, sir. At least tempting word is assuring for me also.
Prabhat,
Tempting. Yes, sir.
OS of monarchy. What is your opinion? Quickly in 10 seconds.
Sir, it is impressive. And that is why I said among the three present.
1.8 is good for you with 50% of patients post progression in the control arm did not receive CDK4/6.
Sir, this is going to happen. As a researcher, I know that presently I am not able to give CDK4/6 inhibitor or TDXD to our patients post progression. So this is going to happen, and we will never have an answer. If considering the carryover effect seen here, I am impressed.
Okay.
I am
No,
not
the
impressed
IDFS
with
is
OS at
impressive.
present. It is too early to say.
Okay. 5 more minutes, Pramod.
Yes, sir. Just while preparing for talk, while searching for more trials, I came up with a consensus paper on bone management with AI. I would like to ask my panel. I have not included that. How frequently do you monitor bone scan, DEXA scan for patients who are on AI?
At baseline and then yearly.
You religiously do it yearly, sir?
Yes.
Arre wah. Even I was not doing it. Any other panelist?
What is that yearly?
Chetan, what did you say? What are you doing?
At baseline and then annually.
DEXA scan.
Which one? Achha,
DEXA.
DEXA. Yeah.
DEXA.
I do it at baseline and in every 18 months.
Every 18 months. Okay.
Yeah.
Dr. Chandrakant?
2 yearly.
2 yearly. So consensus says every yearly it should be done, and especially spine and hip bone should be seen, and accordingly patient should be managed, which even I learned while preparing for this talk. I am impressed that Dr. Chetan is already following it. Anybody looks after KI67 or PATH-CR in ER positive disease?
Yeah, so there was a data from that if the Ki67 is there post chemotherapy still, then it is bad. So from that time onwards, we have right now started doing that. Before that, we were not doing that.
What level of KI67, sir?
So Ki67, if post neoadjuvant chemotherapy, if it is still high, then the prognosis becomes.
10.
Okay. Yes, Bharat sir.
Sir, actually, the main data is in a neoadjuvant poetic and adapt study, if you remember. And what they saw was 10 is a cutoff. Less than 10 is considered as good after some period of some drugs. So, and for this, it is basically a subset analysis in Monarch E did they do. That was presented in this ESMO 2025, where the lesser the Ki after chemotherapy, the better is the prognosis. It is not a predictive marker. It is a prognostic marker. So yes.
No, Bharat, even if you look at it, the European data, if there's a drop in Ki67, it suggests endocrine responsiveness, and even they have thought of taking away chemotherapy in their
That is what,
guidelines.
sir,
No,
So even they are doing that.
Post neoadjuvant chemotherapy. I am
Yeah,
not asking post ET.
so it is with 3 weeks of neoadjuvant endocrine. They look at pre and post. Prabhat, if the data is that if there is a fall to below 10, then
Sir,
actually you don't
paid
require chemo.
neoadjuvant chemo, sir, not neoadjuvant ET.
This data is with neoadjuvant ET, which are speaking.
Yeah, I wanted neoadjuvant chemo.
that is Monarch में sir, this ESMO there was a presentation. So probably the lesser the better post chemotherapy, and it is indirectly a prognostic indicator which tells us the overall outcome. However, giving abemaciclib doesn't change anything. Basically, irrespective of whatever is the Ki67, abemaciclib works well, sir. That
Agreed,
is
sir.
all.
I have included this
No,
slide for
no, the question is Prabhat, Amish here, sorry.
Yes,
The
sir.
final conclusion Ki67 कम होता है या बढ़ता है? Are we
It
changing our
indicates prognosis.
treatment as of today?
No, sir. No, sir.
If we are
So
not changing.
it indicates prognosis as per recent ESMO, what Dr. Bharat
That's
pointed
all. Yes,
according to that
yes.
study. But my point is, wouldn't that indicate that this patient has a chemosensitive disease? And one of the trial where I am PI, sponsored studies, patient are not allowed to switch to SERD. If patient undergoes PATH-CR, patient is not allowed into SERD. That is an exclusion criteria. If after
Prabhat,
hormone
okay.
positive disease, patient undergoes. But here Dr. Bharat pointed out, and that study does say that if Ki67 is dropping after chemo, I am not saying ET. That means it is a good prognosis. But
So I think as of today, if I understand correctly, it is more of a prognostic rather than any
but does
treatment which
drop
you change.
prognosis? What does panelists feel? Does drop after chemo indicates prognosis? But then accordingly, it should be more chemosensitive disease, and we should hop on to endocrine therapy for such patients. Oh, sorry, no, less towards.
Endocrine.
just now this is cross trial lessons just to have what Dr. TP Sahu sir wanted. What will it make OS difference, sir? We have for tamoxifen, initial tamoxifen trial showed at 15 years 9.2% difference, and we are giving tamoxifen to everyone. It took 15 years for even tamoxifen to prove itself. We have changed to AI just based on 2% benefit at 10 years. We are giving extended AI based on just 0.6% difference at 10 years, at 15 years, and similarly adding of OFS did made only 2% or 3% difference. So yes, 2-3% presently at 7 years, 1.8% also makes sense if it is holding on till 10 years. So this is my conclusion slide for endocrine, and that is how if we conclude compare present data, absolute difference of lidera is also 2.8% compared to what extended AI or a CDK4/6 inhibitor have shown. So I am not impressed with the mechanism why G-direction should work, but yes, it has shown 2.8% benefit, which is impressive if we go into how we have changed our practice over the years. That's it from my side. Or I have one
So
thing, trial.
yeah, Prabhat, you conclude if you anything more.
Okay, if I have 2 minutes more, I have just picked
Yeah,
up one
sure.
that we feel that ET, ER positive breast cancer, all breast cancer are systemic disease. And we know that ER positive tumor now relapses after 10-20 years once we stop ET or on ET also. For TNBC, we know that PAT-CR does indicate prognosis. But for ET, we don't think so. Why is it so? Because only 10% go into PAT-CR, or we feel no, it is not at all relevant. Any of the panelists? And would strategies to increase PAT-CR really lead to cure and prevent late relapses, what we are seeing at presently? So I just have had this paper. I don't expect any answer. So we know that there are two trials of adding pembrolizumab and nivolumab, and there they found that those patient who had high TILs or high PDL1, their PET-CR was definitely more. Long-term OS data is still awaited. And so can we make tumor hot? Is there a hypothesis generating trial which I found in this SABCS? I've just included for sake because I found it interesting as a researcher, that if I can make the tumor hot by giving irradiation, then I can increase T cell infiltration, which was their primary endpoint, and PAT-CR. So PAT-CR up to the tune of 30% was seen, which is not seen otherwise. If you don't give RT, roughly 5 to 10% of patients had PAT-CR. So maybe PAT-CR, if now we know it can reach 30%, that may change overall survival for our patients. This is the investigators only on 48 patients data that they feel that it increases T cell and it also increases encouraging PAT-CR rates. So if any of my panelists, I don't think will treat at present. I just kept one slide whether they will change. Thank you, sir.
Thank you, Prabhat. Just one question which I thought is unanswered in the chat. You can take it to anyone in the panel. Simple question. I think it has come from Sumit, and he says that how do you confirm premenopausal status? I'll take it in another way. How do you confirm the postmenopausal? One reading is good enough, or do you want to take it for multiple readings? Prabhat, how do you do in TMH?
Sir, postmenopausal, I just
Let's say
recently.
the 40-42 years age group.
Yes, sir. I have a patient who is 50 years. She was sure that she's postmenopausal. I wanted to take her on an extension of Natali trial going on in my institute. For sake of trial, she's already on AI. For the sake of trial, we did her E2 and FSH, and it turned out she's premenopausal. And that is why I included my first. That is in 45 years. Should I really catch what patient is saying and catch her as
And
postmenopausal or
if you
not?
have one value of which suggests a postmenopausal, would you like to confirm it on repeated testing on a regular interval? Was the question. I
If
think that's
patient is
what.
not on ET, if patient is not an ET, then one value should be good enough. If patient is on ET, then I would like to stop ET before confirming that patient is postmenopausal.
Senthil boss, what is your take? One value is
Last
good
year,
enough,
sorry.
especially for the dicey patients of 40, 42, 43, or do you want to reconfirm on a 2 to 3 monthly interval for a short period of time?
I would generally confirm, especially if it's the age group that you're talking about, Sahu. 42,
Yeah.
43, post chemo, no periods. I would not jump into giving an AI based on one. In fact, even if it is castrate, I would still end up giving LHRH analog for a patient like that.
Okay. Last
I
question
had
to
a
you
query.
before you go for the talk. Yeah,
CP boss,
someone
just
wants to
one
speak.
question.
Yeah.
Just one question. The last year during year in review, we presented an abstract where we use anti-Mullerian hormone. If the AMH is very low, then that probably indicates low ovarian reserve, and for a lady who's not had periods, hormonal profile otherwise matching, you can go ahead with considering her as postmenopause.
We have to do both. AMH per se single we should not do. You should combine with E2.
No, not single.
That
I don't mean single.
substantiates that it is there. You can
Yes,
agreed.
yes.
combine,
Okay.
but you cannot replace.
So we will move on. Thank you, the panelists. I think
Thank you.
someday we'll speak on the fall in Ki67, which is indicating endocrine responsiveness for a 3 to 4 weeks of AI in neoadjuvant setting or endocrine therapy. And can we get away with those costly tests? And could that be an indicator? Because there is good data, at least 2 trials, giving the data of endocrine responsiveness. But we'll move on. And we'll move on to one of the important lectures, what we want to do in this series of deep dive into breast cancer. And I always want to thank Dr. Sandil, who very graciously accepts the invitation. And this is a teaching session. And this is where we want to learn more. So it is statistics, what oncologists should know and how we should be interpreting the Kaplan-Meier. Dr. Sandil, he needs no introduction. And without wasting time, please, Dr. Sandil, the floor is yours.
Thanks, Sahu. Sahu, you will warm in 5 minutes before time.
Yeah, I will do that.
Yeah, thanks. Good evening, everybody. Thank you, Sahu, for asking me to do this talk. It's always a learning experience whenever you go back and read again for a talk, because I've done this a couple of times, but when I go back and read to prepare for another talk, there's still so much that one needs to learn. There's so much that's new. I hope all of you will find this useful. Let's move on. So, many people call the Kaplan-Meier curve a curve that changed the world. So where did it come from? This was in 1958. Two gentlemen from the US, Edward Kaplan and Paul Meyer, wrote to the Journal of the American Statistical Association proposing something that's called as a Kaplan-Meier estimator. When the editor saw that both of them were proposing the same thing, they said, okay, both of you guys get together and send it as a single publication. And that's how you now have the curve that we very, fondly argue about. That's called the Kaplan and the Meyer, or the Kaplan-Meier curve. So what they actually proposed was a Kaplan-Meier estimator. Now, what's this? It's a formula that helps estimating the proportion of patients who are alive at any point in time during a trial. Very simple. So it's a formula that helps you estimate what proportion of patients are alive at any point in time during a trial. And the curve that is plotted based on this formula, or the data that comes out of this formula, is called a Kaplan-Meier curve. Now, this word at any time point is extremely important, and I will keep mentioning this time point multiple times during the course of my talk. So we generally refer to a Kaplan-Meier curve as a survival curve, or this is used for survival analysis. So this is also called as a time to event analysis, and that event can be many things. It can be disease-free survival, it can be progression-free survival, overall survival, time to CNS failure, multiple things that you can look at. So it's not all the time survival. The event can be anything that you want to look at as part of an experiment. Now, this is how generally we would try to describe a Kaplan-Meier survival curve. Okay, so like any other graph that you're seeing, it has an x-axis, it's got a y-axis. The x-axis shows time. It can be months, weeks, days, years, whichever way you want to represent. And the y-axis tells you about the survival probability, which is usually in percentages. Now, each of these vertical lines that you're seeing marks a time period. So this time period is 3 months, this is 6 months, 9 months, 12 months, and so on and so forth, till the time that you're following up patients. Now remember that in a study, not all patients are enrolled together. That means you don't start running the race together. You join the race at various points in time, but very importantly, whenever a patient joins the race, he starts running from here. He does not start running from here just because the experiment is already 6 months old. So this is very important to keep in mind. Now, what are these horizontal lines? These are lines that are representing a period in time wherein no events are occurring. So if you're talking about survival, that means in the first 3 months, you're seeing that nobody is dead. What happens at the 3-month period? You see a drop down. So every drop down is an event. So every time somebody has an event, the curve takes a dip. So you got a time period, you got a period where there's nothing that's happening, and then you got a dip down, which denotes that an event is actually taking place there. What are these vertical lines or the red lines that you're seeing? These are patients who are called censored. Now, this is a very important term. So what does censoring refer to? It could mean multiple things. It could mean loss for follow-up without the event happening. That means you enroll this patient, he or she just ran away at 3 months. So that's a patient who is censored because he or she has not had the event in question. The second thing could be that your patient just went off the study not because of the event, but it could be because of a toxicity. That means you're talking about Natalie and Monarchy. If a patient went off the study not because she had an event, which is an IDFS event, but ended up having terrible toxicity because of abemaciclib and then went off the study, that is also a patient who is censored. Or sometimes what can happen at the end of a Kaplan-Meier curve, you'll see that there are multiple vertical lines. That's because the study has ended, but still there are so many patients who have not had the event in question. Okay, so all of these will come under the broad category of censoring. So lost for follow-up without the event, off the study for a survival or a non-IDFS or one of those events or a definition that qualifies for the event, or the study ends but the event has not occurred. Okay. Now, why is this important? Because this introduces bias, especially when you're comparing two interventions. More the censoring, the less the reliability of the events, because the strength of a Kaplan-Meier curve or the results that you get from a Kaplan-Meier curve, the robustness depends upon events, right? So if you're not having events, the more the patients are censored, the lesser the events, lesser the reliability, greater the bias if you're actually comparing two interventions, right? So this is important to remember. We come down to the bottom, you see that there are 8, 7, 4, 2, 1, some numbers that I have marked. So this is number of patients at risk or number at risk as they call. So let's say you're starting this study with 8 patients. At the beginning, there are 8 patients who are at risk to getting the event. Now time period 1 is gone. 1 patient has had an event, so the number at risk comes down to 7. But look at what happens here. From 7, it has jumped to 4. What is happening? There's a patient who is censored, and there are also probably some patients who are having events. So when the number at risk jumps from one to the other, there are 2 sets of people who are going away from that group. One is a set of patients who had an event. The other is a set of patients who are being censored. Okay, so there are softwares to kind of extract this data and say how many were censored and how many were actually having the event. But let's not get into those intricacies. So a number of risk, that's very important. I'll tell you why it's even more important when we get to the other part of the talk. Okay, now interestingly, you're calling this a survival curve. The event can be multiple things, not necessarily survival, and it's not a curve. You're seeing that there's a line, there's a dip, there's a line, there's a dip. How did you call this a curve? That's because if you're having a study that's got hundreds of patients, you will not see this vertical drop for every event that's happening. Kind of becomes a little serrated. It becomes smooth, and that's why you're calling it a curve. So the paradox is that what you're seeing on the screen, though, is called a survival curve, It's neither looking at survival nor is it a curve. So sometimes what you're saying can be a misnomer. So that's just a snippet. What's the data that you get? The most common thing that we look at in a Kaplan-Meier curve or a projection is median overall survival or median event-free survival. What is this? This is the time at which there's a 50% probability of surviving or having an event. So it's a 50% probability of surviving or having an event. Very easy. How do you do that? You take a line that is drawn horizontally from 50%, drop it down. Whichever time point you're hitting is the median time to that event. It can be event-free survival, overall survival. The other thing that you also look at is what is also called, it's a 1-year survival or 2-year survival or one of these time points that you're actually trying to look at. What you do is just the opposite. You start at the time that you want to look at the percentage of patients who have had the event, vertical line from that time point, and then a horizontal line to the y-axis. Okay, so here at 12 months, you've got about 27% of patients who are still surviving. Okay, so you could look at median survival, or you could look at survival or an event-free, whatever it is at a particular time point. So these are two important numbers that we look at in a Kaplan-Meier curve. Now, what is it that we are very interested in? We are very interested in comparing two interventions. What is it that we are doing when we are comparing two interventions? We are trying to ask the question, is one intervention superior to the other? So when it's superior to the other, you are then measuring the effect. That means, how good is the superiority? So that's called the magnitude of benefit. So now you've got multiple numbers that you're seeing on this. Let's go one by one and look at the relevance of each of these numbers or representations that you're seeing on this screen. So this is a trial that all of you know is dacomitinib versus gefitinib in patients with EGFR mutations. The first number that I'd like to highlight is the median progression-free survival, 14.5 months versus 9.2 months. That is one very common number that we look at. So the median PFS, that means the time at which 50% of patients have not progressed or have progressed, is 14.5 for DACO and 9.2 months for gefitinib. Very easy to interpret. The second number that you're seeing on your screen is something that's called as the landmark analysis. So the landmark analysis here at 24 months is showing that 30.6 patients on DACO are progression-free compared to about 9.6 on gefitinib. Again, a very easy number to interpret. We come down to this number at risk. Remember, we discussed about at the time point 0, all patients who are entering the study are at risk, and then at every time period interval, that number keeps dropping. Patients who've had an event go out, patients who have censored go out, and then finally see what's happening. You're reaching very low numbers. Now, why have I highlighted this? Because the reliability of a Kaplan-Meier curve goes down when the number at risk dwindles down. Now, what is the exact percentage is something that's for debate. General belief is that when the percentage of patients drops down to less than 15% from where you started with, that becomes unreliable. Why are we calling this unreliable? Because remember, I said that the robustness of a Kaplan-Meier curve is based on events. If nothing is happening, it's just a line and is unreliable. So if the number at risk goes down significantly, either because the events have occurred or the patients have gone out for unknown reasons, then this part of the curve becomes very unreliable. So you really can't come to any conclusions based on what's happening in this part of the curve. Until this place, it's kind of okay. You still have about 10% of patients. It's okay. But when you cross this point, the reliability goes down, and then you can't make any interpretations on this Kaplan-Meier curve. So that's the importance of number at risk from a slightly different context. What about number of events? why not easily compare number of events, apply a log rank P, and then say, bye-bye, your P is 0.05, it's significant, so I'm winding it down. One intervention is superior to the other. That must be an easy way of doing it. Why is it that we don't do this? Remember, I started by saying time to event. If you are applying a log rank P just to see if these two absolute numbers are significantly different, that is a fallacy. The reason is that if you're looking at events, you would generally do it at the end of the experiment, or it's at one time point. So it's at the end of an experiment or at the time point. So if you look at 3 years at monarchy, then you can't apply number of events to look at log rank P and significance. You would generally look at it at the end, which is not what we want, because we can't wait for the next 8 years and 10 years to start looking at whether an intervention should be used or not. So how is it that you overcome this problem or the fallacy with comparing event rates? You use this particular parameter called as the hazard ratio. So the hazard ratio here is 0.59. Now what's a hazard ratio? Let's start by asking, what is a hazard? A hazard is always something that's harmful. A hazard is a probability that an individual will have an event at a time point t. Okay? The probability that an individual will end up having an event at a particular time point. So you compare the hazard rate of the test versus the standard. So that's the ratio, and that's how you call this a hazard ratio. So here the hazard ratio is 0.59. What does it mean? That if you took DACO over gefitinib, you got a 41% lower risk of having an event, and the event here is progression. Very simple. 41% risk reduction in terms of having an event for DACO versus gefitinib. For me, the more important thing here is also this 0.47 to 0.74. What is this? This is the 95% confidence interval. Now just look at it like this. If you're using dacomitinib on a patient in the clinic and the patient asks, what is it, doctor, that I'm going to get out of using DACO over gefitinib? One of the ways of explaining that will be you've got a 41% risk, lower risk of progressing. So if the patient asks you again, doctor, are you sure that it is 41? Isn't it 50? Can it be 25? The easiest way to say yes or no is to try to look at this confidence interval. Now, when you do this experiment 100 times, 1,000 times, the hazard ratio is likely to fall within this range 95% of times. So that's why it's called a 95% confidence interval. So if your patient asks you this question, you can say that 95% surety I can say that your benefit is likely to fall between 0.47 to 0.74. So your patient could get a risk reduction that's about 30%. Your patient could get a risk reduction that's about 50%. Your patient could get a risk reduction that's about 1 minus 0.47, whatever that number is. So in order to understand that the benefit that your patient can get is a wide range, we need to have this 95% confidence interval. Now you want this confidence interval to be tight. How close is tight is again very subjective. So let's say you have a confidence interval of 0.2 to 0.98. That's not great. It's very wide because your patients can have benefits ranging from 10% up to 2%. Okay, that's not something that we all want. So that's why this 95% confidence interval is extremely important in terms of how you tell your patients about the benefit that you're likely to get. Not everybody gets the same benefit. It's a wide range. 95% times it's going to be within this range, but I don't know what yours is going to be. What's the significance of this p-value less than 0.0001? If you repeated this experiment at 10,000 times, there's a possibility that in one of those this result is wrong. Okay, so false positivity. Okay, so the 1 in a 10,000 times that this result that you're seeing on your screen is falsely positive. So that's the so magnitude of benefit is measured by hazard ratio or the median PFS or the, the time point analysis. How robust is that result? How sure are you with that result is something that is expressed or shown by the p-value. So that's the difference between the two. You can have a p that is 0.00001, but if your hazard ratio is, let's say, 0.82, I'm kind of disappointed. That's not great. The magnitude is not great. You're very sure that that's the magnitude, but the magnitude is not really great in that particular instance. So that is the importance of each of these numbers that you're seeing in a Kaplan-Meier curve projection. So the next time you look at a Kaplan-Meier curve, try to look at each of these numbers that we are talking about. It'll make much more sense to all of you. But then the question is, which is the best measure to compare these interventions? We'll come to that in a moment.
Boss, 5 minutes.
Oh, lovely. Okay. So I'm showing you an ideal Kaplan-Meier curve here. Okay, a dream Kaplan-Meier, early separation, a super hazard ratio of 0.28. That means there is a 72% risk reduction with whatever intervention you're applying. Look at that p-value. It is 7.8 into 10 to the power of minus 22. Okay, I don't even want to tell you how many times, if you repeat this, you're likely to go wrong once. So this is a Kaplan-Meier. Early projection continues to widen, a super hazard ratio. Median PFS on the experimental arm is not reached, while for TDM1, this is Enhertu versus TDM1, it's 6.8. So lovely curve. You cannot find really a fault with the way this intervention is superior compared to the standard. There's another way of interpreting this curve and getting some numbers out of it. Okay, though this is something, this is the HERA trial. HERA looked at 1 year of Herceptin versus 2 years of Herceptin versus placebo. So 1 year versus 2 years is sitting over each other. This is the no Herceptin curve. The people above this curve, so this is about 69, so let's keep it at 70, about 31% of patients will relapse at 10 years in spite of trastuzumab. 62% of patients actually don't relapse even though they haven't taken trastuzumab. So it's only those small percentage of patients in between these two curves who actually benefit from an intervention. So next time when somebody says those curves are widely separating, then you know that the magnitude of benefit is good and the number needed to treat, which is what I have shown here at the bottom of this slide, 62 to 68. So that's the number needed to treat. So which is 6%. So it's 6%. How do you get the number needed to treat? 100 by 6. So it's roughly about 15 patients. Okay. So for one event to be prevented, you need to treat 15 patients. So that's the number needed to treat. So try to calculate. So the wider the curve, the lesser the number needed to treat. So which is the measure that you will choose in a Kaplan-Meier curve? It is the hazard ratio that you're going to choose. Why is it that you want to choose the hazard ratio? It's because all the other measures that you're seeing here are time dependent. Median PFS, you're looking at 1 time. Landmark analysis, you're again looking at 1 time. Events, again looking at 1 time. Hazard ratio, you're not looking at 1 time. This hazard ratio that you're seeing here is a hazard ratio that is calculated for the whole curve. So whether you're at 6 months, 12, 24, 30, the hazard ratio is the same. Of course, there's something called as non-proportional hazard. Let's not get into that today. We don't have time. But this is something that the software and the computer will calculate and give you a hazard ratio that is constant over time. So that is the reason why if you want to choose one value, that's the most important value that tells you the magnitude of benefit. It is the hazard ratio. It's not the median PFS. It's not the landmark analysis. The others are very easy for us to explain to patients regarding benefits, but remember, they've all got their own fallacies. So I think we are running short of time. So what I will do is I'll go to my last slide.
5 minutes.
Size, right? So everybody keeps asking, so what percentage, what hazard ratio is good? So this is kind of very opinionated, partly my own opinion and partly what I've derived from literature. If you've got a hazard ratio of more than 0.8, That means if your risk reduction is less than 20%, that is very small. In fact, we wouldn't call it significant. Similarly, if your difference is less than 5%, again, that's very small. A large peg is somewhere between 0.8 and 0.5. That means a risk reduction of anywhere between 20 to 50% and an absolute benefit between 5 and 10%. While a huge benefit would be anything that's less than 0.5 or an absolute benefit that is more than 10%. Now, you can argue that you were discussing giredestrant and monarchy and all those things, 2.5%, 3%. I'm not saying it is bad, but all that is, important to understand is that that magnitude of benefit is small, but of course, it keeps widening as time goes by. That's again something that's very important and needs to be taken into consideration. How do you get better interpreting? Keep doing this all the time and again, guys. If you keep doing it, you'll really become great experts in Kaplan-Meier, and that's what will help you assess benefits of all of these interventions. Thanks, Sahu. And if there are any questions,
Thanks, boss. If you have the chat, there's only one. There's a question by Rohan. Can you take it? I understand you have already told it quickly.
How is the 95% contribution? So again, okay. So it's like it's the calculator which actually does that. Everything is a software. I don't know the formula. I generally don't go about teaching people how to use these formulas and calculate. So all of these are what the software calculates and gives you. You don't repeat it 100 times. It tells, it's like the p-value. How do you calculate the p-value? Do you say, did you do it 10,000 times and then say that once I went wrong? No, you don't do that. It's a value that's calculated. So when you calculate it and you see that value, that's what the interpretation of that particular value is. So that's how you don't do it 100 times.
Amish's hands is up.
Amish here.
Hi, Amish. Good to see you.
So I cannot stop asking you questions. Sorry, Senthil.
Go ahead.
Time na bhi late ho raha ho. So Senthil, Kaplan-Meier curve, what you explained again, I think it is an amazing revision. Assuming that at the median event, whatever it may be, EFS or OS, the difference is say 3 months. But many a times we see that in the tail, at 2 years time point and 3 years time point and 4 years time point, 20% of the patients are alive compared to 9% and 30% alive compared to 14%. Are these pre-designated time points and are they statistically significant? How would Dr. Senthil Rajappa read into these type of results?
So I think, again, let me reiterate the point that it's not the most reliable way of interpreting a curve. The best thing to do would still be to stick to the hazard ratio because that's what is constant over time. And as you rightly pointed out, these differences keep varying at various time points that you're analyzing or looking at these results. Now, these are not analyzed based on time. Now, when you are analyzing events, you could do it two ways. One is it's an event driven or it's a time driven. Most of the time in today's day and age, randomized controlled trials are all event driven. They're not time driven because many times you say, I want to analyze at 30 months and then you see that hardly any events are actually happening. It's a waste of time to do that analysis because you don't get anywhere. So today's day and age, we don't do an analysis based on time. We do analysis based on events. And if you want to really know whether that end point or the analysis at the end is reliable or not, you need to look at the number at risk. If you see that the number of risk at that point in time is hardly any, then that number is not reliable. Let's say at 2 years, 20 versus 15, if the number of risk is actually 5% of the patients who started on the study, then that result is not actually reliable. So these are not planned. These are arbitrary analysis at various time points because trials are not time driven anymore. It is event driven. So you have to look at the reliability and then interpret those numbers rather than blindly saying at this point in time it's 2 or 3 or whatever it is.
Senthil, sorry, little bit I'm confused here.
Okay.
Assuming
that means I'm successful.
Assuming you start with 200 patients at risk at the baseline.
Okay.
Okay. And say event at risk at the end of 3 years is 5 and 3 in the two arms.
Okay.
That means 95 out of 100 either have died or they have been censored.
Yes.
right? So isn't that data more robust and more final? I am confused here.
It's not
That
reliable because there
assuming
are.
at the end of the study, there should be minimal patients at risk.
That means if you follow these patients long enough, so when will they be at risk? So if 24% are still not having had the event, then you should have 24% of those patients at the bottom at risk.
No. Yes.
Yes.
Okay. Correct.
So
Yes.
if you say that 24% are not there and only 5 are there, that means there's something more to it.
Right. Okay. So I understand. If 24% have not died, then those 24% should reflect in the at
In
risk
the
also,
risk,
right? That is
correct,
what you are saying.
correct,
Okay.
correct, correct, correct,
Okay.
correct.
I
Lovely,
got it.
good.
Yes. So no more doubts. Confused. Clear.
Super. Okay.
Thank you. Thank you, Dr. Sandil. So there are a few more things on the chat. Tried to answer one of that. That is
Okay.
a proportional and non-proportional. You can take it further. So we'll go on to the next panel, and that's Amish. Uh, so he'll be taking up the early HER2 positive breast cancer, and his panelists are Dr. Nikhil from Apollo Hospitals, Hyderabad. He's a director. Dr. Nilesh Lokeshwar, his screen has lit up and I can see him. And he's from Mumbai, Lilavati. And now we have Bharat Rangarajan, who is from Coimbatore, again a dear friend. And Rajiv. He's again expert from Chennai, a senior medical oncologist, and now very much interested in geriatric oncology. Amish.
Yeah. Can I share my slides because it says that I have to be given the right.
Please, someone has to give Amish take away this slide, please.
I already have loaded the backup because unlike
Excuse
Senthil,
me,
many a
can
times.
someone just take away give the screen to Dr. Amish? Yeah. निखिल वैसे ही दिख रहा है तू जैसे बोला था मैं
कैसे दिख रहा है
वैसे ही
Achha, my slides are visible.
Yes, Amish.
Okay, so we move to the next. I assume the next is also visible. At any point of time, if there is a hitch, I would request the organizers to take over and project my slides. So let me start with extremely dear friend, Dr. Nilesh. Nilesh, why do we discuss these papers? How many times, based on ESCO, ESMO, SABS, WCLC, before the regulatory approvals, you have changed your practice?
Almost never before regulatory approvals. But having said that, I think this is the most impactful thing about being an oncologist. I think most of these meetings, the points that are discussed, before that, we really don't know about it. We know about the early stage of disease. We know about the early stage of the trials. And most clinicians who do these trials will reserve them for the best meeting of their choice. And I can tell you that all of us, everyone on this panel and this meeting attending today, eagerly awaits the updates on these major conferences.
Right. Nikhil, so this is, Senthil also has shown, this is Destiny Breast 03. Assuming this is presented 10 days back in SABCS, and you see such a huge separation of curve, and the hazard ratio is 0.28. And even Senthil also said कि ये Kaplan-Meier curve में उसको कोई गड़बड़ नहीं दिखा था, right? Would you change your practice based on this, or you would want the regulatory approval?
So definitely, I mean, with this data, I would look forward to this trial to be implemented immediately in the practice. Same time, I would want to discuss the same thing with the patients also, because at the end of the day, there is not regulatory approval. So there lies that I would say treatment dilemma for me also, that the data is there, how to implement it immediately with the patient. But sometimes you will feel that we are doing disservice to the patient by not applying this data to the patients.
Perfect. So I think if I understand correctly, all of us eagerly await these updates. Many a times we'll wait for regulatory approval, but not necessarily will change our practice. unless and until there is a huge difference, probably we'll discuss with the patient and get the good consent form and change our practice. Okay, let's come to our first paper. We are going to discuss three papers, and depending on the time, I'll stop exactly at 30 minutes, Tarini, whether we complete 1, 2, or 3. So this is the first paper, that is Destiny Breast 05. Trastuzumab deruxtecan in residual HER2 positive early breast cancer. This NEJM publication was 6 days before. And this was the study design where they had taken the patient who had residual disease after neoadjuvant chemotherapy, but at the baseline, they had taken a high risk patients. And these high risk patients are basically either initially inoperable or operable EBC with axillary node positive disease after neoadjuvant treatment. So these are the patients who had residual disease and a significant amount or a good amount of residual disease, which was there. These are the patients who were randomized into 1:1 TDXD for 14 cycles versus TDM for 14 cycles. And because it was TDXD, ILD monitoring program was standard, which was seen, and that was something which we all do of that. Now, let me come to Bharat. Bharat,
Yes, sir.
you are a little conservative on the side. So this question is, what was the need of this study? See, this is yesterday night, 12 midnight, I have downloaded. I don't think today the NCCN guideline has changed. And
It has not.
TDXD is not been incorporated into the NCCN guidelines as yet based on that paper. Why I'm asking this question is that if you see the January 2025 NEJM, 8.5 years of Catherine trial data is published. And in this, if you say at the end of 7 years of follow-up, IDFS is 80%, OS is 90%. There is no question of TDXD ka cost or ILD, and neither of the trial, nor Catherine nor DB05, have reported a single death to TDM1 or headache of ILD monitoring was there. So with such impressive data of Catherine, Bharat, do you think that we require any of such study today?
Sir, actually, you asked that question to Nikhil, and at that point of time, before regulatory approval, you had asked that question.
Yes.
And in my mind, I was thinking of the same thing. Before regulatory approval, two things that I would be worried about is even in the metastatic setting, as far as I have used, my use of TDXD is extremely, extremely rare because I'm not in a very high socioeconomic, patient pool. So it's quite rare. Even there, I hardly am able to use 5.4 milligram per kg. This is the truth. Second thing is, I have, even in that small number, I already have one patient I've lost to ILD and one patient has got severe ILD. Now, with this sort of worries, before regulatory approval, I would be very scared. But having said that, what you asked, despite being, Catherine being 8 years old, at one point of time, Destiny Breast 05 is also going to be 8 years old. And from what hazards we are seeing now, it is going to have a good hazard for OS also. We don't have that hazard, but the most likely it will not turn out like, say, an Adora or something where, it did not pan out that much. But still, there will be a significant improvement. And uh, as you rightly said, these are all fairly locally advanced breast cancer patients. If you're getting more than 90% survival, if you're getting a nice 5 or 6% delta in the OS, which a good hazard at the end of this over Catherine, yes, we would change. I
Okay.
think that
Right.
despite
Dr.
Catherine, we would
Rajiv,
change.
Dr. Rajiv, Bharat wants 5 to 6% of delta change to change his practice. What would be your thought process? What would you have expected from this study?
I think
And again,
comments.
I'm putting DBO3
Yeah.
here because we had that ratio 0.28 in metastatic breast cancer. Now, exactly the same comparison is happening in the adjuvant setting. Dr. Rajiv.
Yeah, so I think Dr. Amish, you had rightly pointed out to the inclusion criteria of this trial. So we all have patients who actually do very well in most of the dual anti-HER2 blockade. And then sometimes you'll have a small residue and then you are confident in using TDM1, and we know that most of them will be salvaged by that. But then we do have patients who have high nodal positivity at the end of all this, and sometimes you will have very high risk to start with. And we have definitely clinically seen that some of them do fail on TDM1, and especially in CNS metastasis. So I would say that there is a need. As you rightly pointed out, there is no, if you have 80% survival with the TDM1, there is no point in jumping and changing for all of our patients. But I think a ultra high risk patient who has definite risk of systemic recurrence and CNS failure, even after TDM1 is the one patient where I would discuss straight away, because we knew that the TDM1 was not sufficient, and we are putting some of these patients on TDM1 with no real other option. So I think that's one subset where I think it will make a meaningful
It makes
benefit
a
in
difference.
our
So
population.
what Rajiv is saying, that there are very high volume disease left behind after neoadjuvant treatment, and TDM1 is probably not sufficient. Tarini, I would like to bring you here. What delta would you have expected from this study to change your practice?
I think if you look at the IDFS,
What delta would you be comfortable? See, Rajiv said very clearly.
apart from delta, I would be looking at the hazards. The delta was one part of it.
What
I look at
hazard?
the
What
hazards.
hazard? What hazard ratio?
I
Senthil said
think
less than 0.8, more than
yeah,
0.8,
yeah. So
useless,
so
point
so
0.5 to
so
0.8, good.
so with a drug like TDXD, toxicity and the cost, anything below 0.8 is something which I'll be happy.
You would be okay. Be less than 0.8, you would be happy. Okay. Nilesh, Rajiv pointed out a very, very important point here, that with Catherine data of 8 years of follow-up, not every patient you would want to change to TDXD. But if the trial is positive, you have to give the option. Nilesh.
Yes, yes. So, so there are three things important for this trial. One, of course, is the highest of the high risks have been taken: T4, N1, N2, N3, and residual axillary nodes. Also, we now have a drug that has better CNS activity also. So that will reduce your CNS, hopefully reduce your CNS relapses. And a trial done today is probably more representative because the number of patients in the Catherine trial who received a dual HER2 were much lesser. So they were about 20% in that trial. So there are many important things in this trial.
So this was the primary endpoint, Dr. Nikhil, for which the study was done. And we have a hazard ratio of 0.47. Tarini is very happy about this hazard ratio. And there is a delta of almost 9% in the 3-year invasive disease-free survival. Nikhil, you are impressed?
Absolutely. I'm more impressed than Tarini here.
You're
And
over impressed than Tarini. Okay,
more
perfect.
impressed, I said. And again, we are looking at what Nilesh has just now mentioned, that we are looking for a very high risk patient. So when you showed the first slide about Catherine inclusions were different, and this particular trial's inclusions were quite different. And that is where we stand. In fact, these are the patients we, as in India, see more often, locally advanced and treatment, post-treatment residual nodes. So something which I believe is quite an important, and I think that's is definitely quite a convincing study in terms of in terms of the outcomes.
Right. So Bharat, sorry, Nilesh, this is the Catherine data at 3 years, and we have DB05 at 3 years. So apple to apple comparison. TDM1 there it was 88.3%, and here it is 83.7%. So does it mean that because we had more patients on dual anti-HER2, TDM was less effective? Uh, why is there discrepancy? Or because we have a high risk, that's why TDM1 was less effective?
Probably a combination of both.
Probably a combination of both. Bharat, in
There were a lot
Catherine,
more. There were a lot
yes,
more node positive patients in the Destiny Breast trial. Nearly 80% of patients were pathologic node positive. So
right,
I think there were more
absolutely,
high risk patients. So
right.
maybe TDXD did better, and TDM1 didn't do as well.
Didn't do as well. So this was the basically the data which you all were saying, 25% versus 50% inoperable in DB05, and trastuzumab plus pertuzumab was the reverse, that in that it was used. So probably in such patients, TDM1 was not very effective, and this was the third curve of distance recurrence-free interval. Okay, this was the interstitial lung disease, is the interest which is there. Bharat, you have lost one patient. Here, they lost two patients on interstitial lung disease. And grade 3 were 7 patients, grade 2, 52 patients. Remember, grade 2 means you can't give TDXT ever again. Uh, does this worry you to change your practice, or you say that in the hazard ratio when it is 0.49, it's okay to have this much of ILD?
I think yes, that is what I said. Despite the worry, I would love to have the regulatory approval, but even without that, I think we have to start discussing, and we would give and monitor for the ILD like we do, maybe even more stringently. This is an adjuvant setting where losing a patient is much more. It's more heartbreaking for us also. So we'll monitor more intensely, start the steroids more quickly, but still offer the patients
Still offer
TDXT
that.
also.
Okay. Yes, Nilesh.
So I think there were 800 patients on this arm. 9% odd had some form of interstitial pneumonitis,
Correct.
and there were 2 deaths out of 800.
Correct.
Right?
Correct.
Also,
And there was 0 on TDM1.
correct, related to interstitial pneumonitis. Correct.
Correct.
So if you look at the magnitude, it's of course it's adjuvant. There's no doubt about it, and of course it needs to be monitored very carefully. But compared to the benefit that it gives, I think it's a reasonable side effect to accept in this situation.
Okay, Rajiv, last slide on this paper, and then we will move forward. Primary endpoint of this study was achieved. Very high-risk patients were included, and you were worried about these high-risk patients. Okay. Apart from TDM1, we don't have anything except if you want to consider niratinib as one of the option as an extended adjuvant program. Survival data is not mature as yet, while we have 7 to 8 years survival data in Catherine, and it's quite impressive. And we have 2 deaths with 9.4% ILD, SAE of interest. Rajiv, would you change your practice based on these data? Yes or no? We have Rajiv or we have lost him? Okay. Nikhil, Bharat, and Nilesh. Yes or no?
So I think, to my mind, for these ultra high risk patients, I think I would definitely consider for this particular treatment regime. Not for all comers, I would say at this point in time, because I'll be concerned about the adverse effects, and we probably might just get away with like a drug like a TDM1 in those patients. But just a I would say low T patients, no negative at the end of residual disease. These are the patients I would still stick to TDM1. But anytime, as per the criteria, like a locally advanced and node positive patients, which to my mind, I think this drug has shown the maximum benefit, and that's where we stand, and that is where we should consider applying this
So
particular.
answer is yes, but not in all comers, right?
Yes.
Okay.
Yeah, one more point, Dr. Amish.
Yes, Dr. Rajiv, we were asking you question.
Yeah. So the differential toxicity also we should consider, because in TDM1 also it's not an easy drug to give. Some patients do get into this thrombocytopenia and transaminitis issue and neuropathy. So now we have a choice, where TDM1, if intolerance also.
Will you change your practice based on this data, Rajiv? That is a question.
Yes.
You would.
Yes.
Okay. Bharat?
Yes, yes.
Yes. Nilesh?
And for almost all comers.
Almost all comers. Okay. Nilesh?
Yes, for patients as per the inclusion criteria.
As per the inclusion criteria.
And,
okay.
and in the study, 70+% of patients could complete the complete cycles.
Complete cycles. Perfect. I think I am a little skeptical about changing my practice at this point, because I would like to know who are those 80% of patients on TDM1 who have not progressed. And there is a 3-year IDFS of 83%. If I know that those are the subset of patients who do not require any upscaling, I think I would reserve only select patients. But again, we need to have more data. As of now, this paper looks practice changing, not in all patients, but.
Sir, I know I'm not supposed to ask a doubt, but even with Catherine, we never got a biomarker or anything that could tell us who were the persons who could get away with trastuzumab alone and who needed TDM1.
So we will
HER2 positive, we don't have
the
such
third study of the
biomarkers.
biomarker. Bharat, let's move. Already 15 minutes
So
are
Amish
done.
boss, why didn't we ask this question to Catherine?
Sorry?
Who was the patient who just get away with trastuzumab?
There is no such
But
biomarker in HER2 positive disease. No such
Darini, you know
reliable
Kathleen
one.
very well, so you can ask that question.
Okay, last question before you move on by Chirag sir.
Yes.
Dr. Amish, you can answer it. What maturity of data, 3 years, 5 years, what are you looking at so that you can change practice?
Right. So my point is 3 years hazard ratio is good enough for me in such high volume, high risk disease. My point is with TDM1 showing such a good data at the end of 7 years, I would love to know, are there any patients who will not relapse, who happen to be those 80% at the end of 7 years? I would not give TDXD even though it is category 1. But again, we have to give option to the patient. This is my perception which I am telling. 3 years data, follow-up data is good enough for me to make my decisions. Okay, the second study, we are 16th minute in the panel, neoadjuvant DB11. In fact, Nikhil told me that there is a full text paper publication on this. Till yesterday, it was not. It is in the process, and I have little bit details of manuscript, but I'm sure it will be published as a full paper. Current practice of all the panelists. Let me start with Bharat. Bharat, in the neoadjuvant setting, treatment naive patients, we use TCHP or THP. Anything else do you use in your patients who can afford and who are eligible?
TCHP as of now.
TCHP. Okay. Nilesh?
TCHP in most, in those who can't afford TCH.
Acha, those who can't afford. Dr. Rajiv?
TCHP or THP.
Nikhil?
Yeah, kind of agree. Mostly the TCHP in the fitter patients,
Okay.
otherwise
Perfect. Perfect. Okay. So basically, Nikhil, PAT CR of 45 to 50% with these. In fact, 40 to 50% is what has been reported in the various. So are you happy with this data? Because these are the patients, there are some patients who are LABC also. And during my DM time, we used to divide into EBC and LABC. Now everything is into EBC, basically. So are you happy with this PAT CR? You think that you need more PAT CR?
I think this number is slightly low. I would say the numbers are slightly higher than this. Maybe I would say around 58 to 60%. The numbers are even higher for the HR negative patients than the HR positive patients. If you look at all the various studies which had come in this space, whether you talk about, I would say those TCHPs, all those trifinas and neocarp and all that.
So 44% to 60% is what
60%.
has been reported in the multiple this
Correct,
thing.
but mostly if you see at the newer data, I think mostly are touching around 55 to 60%, almost in most of the studies.
Perfect. Okay. So now, Nilesh, you said TCHP so confidently. Help me understand. Is this the standard arm as compared to the experimental arm they have taken?
So, if you look at the standard options that are available,
No,
both
those options are multiple. I asked all the 4 panelists and they said TCHP.
So-
Nobody mentioned AC followed by 4 cycles of THP. Not a single panelist mentioned that.
Absolutely, because that's our current practice. I think most of us try to avoid anthracyclines in this group of patients.
So
And we
would you have liked to see 6 cycles of TCHP as the standard arm in this study?
Yes, for my practice, yes. But if you look, the way they have balanced it is to include only 4 doses of TDXD before surgery, and that could be one reason. Also,
So they
the
have replaced
authors have
AC with
claimed that it's an
TDXD.
international multi-center study where in many centers AC is used as standard, and therefore they've used that protocol. Yes, but it would have given me more clarity in my practice, of course.
Nikhil, you can search later. I'm showing the standard slides. Don't worry, I'm not cooked up these slides.
No, I had sent you the article.
My point is that we last 4 years we have discussed anthracycline free, and suddenly now today I have a trial where AC is still the part of the standard arm.
Yes, I think, but at the same time, I think with all the understanding what we have over a period of time, whether you use anthracyclines or not in this particular setting, if you are using dual HER2 blockade, I think the outcomes are more or less similar. So probably we may not see another trial over here with the TCHP over here. I think that is almost impossible. And I would say that the outcomes are more or less comparable, whether you talk about ACTHP versus TCHP and all that. So I think this comparator,
This comparison is okay. Fine.
to my mind is fine.
Perfect. Bharat. if there is no PAT CR after TDXT, we are going down to TDM1. Does it sound little downstaging, or you are okay because we don't have anything else to offer? Bharat?
That is a bit counterintuitive. But the thing is, now we can't compare Destiny Press 5 and then 11 and then say that, we have to extrapolate this and that. This is going to be difficult because even the AC-THP arm in this goes to TDM1, whereas on that would not be the standard now if this become TDXD becomes standard of care. So every trial that problem is going to be there. By the time the trial accrues and finishes, there is going to be new data that makes it a little redundant. So I mean, there's no choice here. But having said that, I'm sure that if there is TDXD and THP and there is no PATH CR, many of us may actually in practice extrapolate and use TDXD rather than TDM1. That may happen over time. We may not have data for that. Of course, you will put your arms up and say that is wrong, there is no data, but that's what's going to happen in practice.
Right. So in TNBC, in neoadjuvant pembro plus chemo, if the patient achieves PAT CR or doesn't achieve PAT CR, they had continued pembrolizumab.
Yes.
So I think here they could have continued TDXT also as one of the arm. Nilesh, TDXT alone arm was closed for multiple reasons: low PAT CR, low likelihood that TDX would be superior, and the timing of surgery. Again, little counterintuitive. Does it mean that the biology of the disease in neoadjuvant setting is different from metastatic?
Possibly, yes. And also, while they had closed this arm for statistical reasons, the PAT CR rate in this arm was a healthy 40+%. So it's not that TDXD as a single arm is not working. I think whatever they've analyzed, it has a PAT CR rate of 44%, which is equivalent to a lot of other regimens.
So 56% PAT CR here versus 44% PAT CR in TDXT. Nilesh, if I am an ethics committee or data monitoring, I would close that arm.
Possibly.
Right. So this is the primary endpoint.
Yeah, can I add a bit over here? Now,
Yes,
technically, when you
Nikhil.
talk about TDXD, it is basically a single HER2 with the chemotherapy versus here we are talking about a dual HER2 with chemotherapy. And that is where I believe the delta has come from. And that's where, to my mind, why this number have been bit less for TDXD. Had it been like a TDXD plus pertuzumab, maybe number would have been a bit different.
Like DB09 in metastatic disease. Then probably this would happen. So there is no end to this thing, but I think this what the study said that TDXT alone in the neoadjuvant setting probably is not sufficient. I think that is a very good take-home message which I have taken. Bharat, primary endpoint achieved. Happy? Delta of 11.2. And if you see RCB, the delta is 12.2. Good data in terms of the such patients.
Good data, but here I'm not sure that whether we will change practice immediately.
No, I'm not come to that.
To this.
I'm just saying that are you impressed
Good
with
data.
this? Good data.
PAT CR data in this percentage difference is good, but it may not really make a difference in the long
May
run.
not.
So we have to wait.
Rajiv, the delta
PAT
of
CR alone.
12.2 in PAT CR, would it make a difference in EFS and OS?
I think we should look at the intent of this trial. If you look at the inclusion criteria, we had a very high risk disease with inoperable disease also being part of it.
Yes.
And there was that time anthracyclines were being part of the neoadjuvant setting, and the idea was whether we can avoid anthracyclines here, which I think they have achieved. So if you can want an anthracycline free regimen and 4 cycles of TDXD can replace that. But then, as we discussed, we have already shifted goalposts. Many of us have shifted to TCH and then to THP in majority of the patients. So, if you have a very high risk disease and then you want to avoid anthracycline, I think there is data now. But as Bharat really
So
pointed
high
out,
risk, why TCHP also does not have anthracyclines. Does this trial answer that question that you can avoid anthracycline, Rajiv, or does it answer the question that TDXT is better than 4 cycles of TDXT and THP is better than AC and THP?
yes. So that means it's an anthra-free arm, which is
We
actually
already have
shown.
TCHP as one of the arms,
That's
right?
what. So I think the goalposts are shifting when we
Okay.
are looking into these trials. Yeah.
Right, perfect. Okay. The Tarini boss.
Yeah.
Do you think this 12.2% delta would change EFS and OS in times to come?
Difficult, but I think two things I just a comment to make. Neither Anthra or neither Carbo is anymore a part of any of the modern HER2 targeted therapy neoadjuvant regimens. Neither carboplatin in now in more than one trial has shown it does not add. So we should be just taking out carboplatin. Even anthracyclines, it does not add anything. Again, two trials have shown that. We presume that it is happening. Why this trial did it? Because it must have been conceived in 2018 or 19, where this trial was evolving. So they don't cannot change the data set. The last thing, I again a little bit differ from Rajiv. It is that if you look at the TDXD alone, PATCR, it is as good as AC followed by trastuzumab taxane. It is nothing great. So why would I waste a drug in the upfront and not use it in the later lines where it is given excellent hazards ratio? So
So,
these are the
Tarini,
small things.
nobody is arguing that TDXT alone is a good choice. I think that is something which is closed, and I agree with you. So this, thank you, Tarini. Sorry, I have 3-4 more minutes, and I have one study more to go. If you have not listened to Senthil Rajappa's talk, I think this is the classical Kaplan-Meier which revises everything which has Senthil has said. And I would say that Tarini will send you the video recording. Those who have not heard, please hear, and then you will understand what does censoring mean, what then the numbers at risk mean, and when the numbers at risk are the one where you already have more than 70% and 80% of the patients still have not relapsed. So the numbers are here not matching. The censoring is a lot, and you need to undergo. Although this study said the hazard ratio in IDFS is statistically significant, and that is something which, if you see the oncology community, everybody is buzzed with this particular trial, and they all say that this
Can
is
you go back,
definitely
Amish
going to
boss,
change.
for the last slide, please? Can you go back? Yeah.
Yes.
So how is this statistically significant where the CI is too wide, even crossing one?
No, I'm not saying. I said exactly the same, Tarini. I don't like this
Okay.
Kaplan-Meier curve. What I'm saying is Senthil has explained it so beautifully
understand.
that people, those who have understood this, they would understand this is not a good Kaplan-Meier curve to follow.
Yeah.
That
And
is
even
what I'm trying to say.
17% loss can also happen by giving TDX.
But isn't that Kaplan-Meier curve an immature data?
It is just 10% maturity. Yeah, matlab you don't I don't read anything in that. But even apart from that, everything what Senthil has said, applies to this KP curve. So there's something which I really liked here is drug-related ILD pneumonitis, because we had given only 4 cycles of TDXT. It is 4.4%, and it is comparative to that of the standard arm. So this is something which is the beauty, that you just do away with 4 doses of NHER2 and then give 4 doses of THP. I think that is something quite impressive. 50% of patients received in the THP arm received TDM1. I don't know what happened to remaining 50%. My last question start with Nilesh. Nilesh, is DB1 practice changing? Even assuming that regulatory approval is here, I would twist little bit. Are you impressed with the current data to change your practice?
So I'm not terribly impressed, and I'll tell you one more reason why. At the end of the day, it is 8 cycles of an anti-HER2 therapy versus 4 cycles. That is a comparison which is also being made, because the other arm has got only 4 cycles of HP, whereas the study arm has got 8 cycles of therapy, and that itself could explain the difference. So maybe if you had given 8 cycles of HP as compared to this, the difference would be less.
Absolutely. That is exactly what I said in the beginning. Why not TCHP arm as one of the standard arm, which is there? Nikhil, practice changing.
Can I make another point? Sorry,
Yeah,
Nikhil.
please,
So
Nilesh.
also, if you were to compare this with the Catherine data, their patients received 6 cycles of chemotherapy as well as HER2, right?
Right.
So that again would explain the difference between the two studies.
Absolutely. Nikhil, we have less time. So practice changing, even if the regulatory approval is there, yes or no? Just. You are unmuted. You have to unmute.
For now, not to my mind.
Not to your mind.
Because for PCR is one endpoint which probably, I think need to be taken.
Not enough, correct. Bharat?
No, not yet, not practice changing. And as I said, this 12 to 13% delta is still, 4 versus 8 cycles of anti-HER2. I don't think it may change in the long run. The OS and EFS may not change in the
You
long
may
run.
not change. Okay, Rajiv, yes or no?
Not practice changing, because again, with no PCR changing into TDM1, I'm sort of confused and I'm not
I
sure
also
that's
agree with
effective.
all of you. Tarini, you can put in the chat because I have just 2 more minutes, whether you agree or not. But
Already done.
I feel that the oncology community, which is abuzz with this, is something which, at least I don't agree. Like all the panelists, Indian oncology community does not agree of those who are present here. Third is very interesting. I love this. I'll quickly go through it and then I'll ask 1, 2 questions to everyone. This is a Fertide. The Fergain study, if you remember, chemo-free regimen. So there's a particular patients who were given only HP with or without endocrine therapy. At the end of 6 weeks, if they are on the PET scan, they are responding. Then they continued chemo-free regimen for total 6 cycles. Surgery. If there is a PAT CR, again, no chemotherapy. At any point of time, non-responders, you add TCHP into 6 cycles. So here it was a TCHP into 6 cycles as standard. 79% of the patient responded to on the PET scan, but 37.9 out of them had PAT CR, which was there. Lancet 2024 April, this is the second primary endpoint which was published in Fergain, and they said that 3-year IDFS of the patients who achieved PAT CR and were not given chemotherapy, 94%. Bharat, do you practice just yes or no?
No.
Rajiv, yes and no just.
Sir,
Yes, Bharat.
for very old patients or patients who cannot, yes, but
Have you
otherwise, no.
practiced it in your practice? That is a question.
Once for an older person who is
One for
74.
older. Rajiv,
Yeah.
yes or no only?
No.
No. Nikhil?
No, till now, no.
No. Nilesh?
No, but the one patient who I treated with this after 2 cycles went to PAT CR and refused any further treatment.
Okay, perfect. So for guide study, they did a 3-time point garden reveal of the ctDNA baseline before the third cycle starts and the pre-surgery. What they found that the detection rate of ctDNA positive was directly related to the stage and the lymph node positivity. Higher the lymph nodes positive, higher is the ctDNA, which is expected. ctDNA clearance correlated with the PET response, and this ctDNA positivity at baseline was with worse 3-year IDFS, and ctDNA positivity at pre-surgery was associated with worse 3-year IDFS. Nilesh, this is the last question to all of you, and then I'll conclude my panel. Assuming that you believe in this ctDNA as a science, because I think 24 and 25 in breast cancer is ctDNA, ctDNA, ctDNA. If you have decided that you will give chemo-free only HP plus endocrine therapy, and if you find PET CT negative, and you say patient will go for surgery at nurse 6 cycles, but if the ctDNA is positive based on this data, would you put them in chemotherapy before surgery, or you would go ahead and give them?
So we have this data about the excellent correlation between the CTDA and the response, correct? But we don't have data yet about by adding chemotherapy, are you going to be able to change that at a later date? So I think this is purely investigation at the moment. Extremely interesting, but investigational.
Rajiv.
True. I won't change practice based on this, but yes, definitely in the future, it's one of the options. Yeah.
Right, Nikhil.
So I think we are going to see more and more studies with like a ctDNA, MRI responses, PET responses, and very likely this is going to happen. But for now, I am not going to use it immediately in my practice.
Okay, Bharat.
As Nikhil said, maybe not for today, but trust me, in 5 years, we are going to be definitely stratifying based on PET and ctDNA and avoiding chemotherapy in this situation also.
Interim
Like
PET.
when we started, we were not doing oncotype TX for everybody. Today we do that and avoid chemotherapy. Similarly, we will do this in 5 to 6 years.
Right. So I would take it Fergain also was a phase 2 study. Okay. And it does not have inclusion in many of the guidelines. So when I decide to give a chemo-free regimen in my patients even today, based on this FIR guide, I would definitely jump to chemotherapy if the ctDNA consistently remains positive. But again, this is all individual thing. We will need more data of that. With that, I close my panel and I thank all the panelists and I thank Tarini for giving me this opportunity.
Two questions
Thank you.
and final thing of again, people have to read the protocol. It is extremely undoable in practice. The MR standards, the PET standards, we discussed in TMH panel. It's really very impractical except for academic setups. To come to clinics is very difficult. So second thing, what was the ctDNA? It was tumor informed.
It was tumor informed, garden reveal.
Yeah, so that again becomes something that people have to remember. It just would not be any ctDNA. So I will just have one question, which is there in the chat. Dr. Amish or anyone in the panel can take it. There's a question by Chainika Datta. Like, why is there ILD with TDXT? What is the mechanism of action?
Okay. Nikhil, Nilesh, anybody would like to take?
It is more to do with the deruxtecan component of this one, which is a more of a typically has been shown with so many, I would say, ADCs in the similar space. I think it is more to do with the interaction with the stimulation of those fibroblastic factors and growth factors and all that. And that has been a consistent finding with, various, I would say, deruxtecans and govitecans and all that. So we do.
Anyone wants to
So
add on?
payload and bystander effect in with deruxtecan is seen higher in TDXT because the payload also is high, 8:1, and bystander effect as a result is high, and somehow it is higher in the lung, the bystander effect, and that's one of the mechanism by which ILD is higher with TDXT.
And also there could be a lower expression of HER2 and this drug does act in HER2. So that also does add to the ILD and bystander effect is something that all is speaking about. So this is the thing in the chat. Thank you, Dr. Amish. Thank you, Nikhil, Nilesh, Bharat and Rajiv. Thank you. And we'll go to the last panel discussion. And this is by Prasad. He'll be doing on early triple negative and it will be, and Prasad Narayan is a lead consultant. He has shifted base now to Manipal Hospital, Bengaluru. And his panel, we have Indranil from Kolkata. We have Amish again, he will continue to enlighten us. Suman, our medical oncologist from Fortis, Gurgaon. And Gurugram, sorry, it's not Gurgaon anymore. And Ashish, from Vellore.
Hi, good evening. Thanks, Dr. Sahu, for this opportunity.
Yeah,
So
your mobile is
when
visible and you are not.
I'm
Yeah,
keeping out.
thank you.
Yeah. So when I was asked to, so all our panelists are there, right? Bishwajit, Ashish, Amish sir, Suman, and Indranil, or one person is not there.
Biswajit might be the person because he told me that he's
Right.
on a move for a flight. So
Dr.
the flight
Indranil
was
is there.
altered.
Indranil, you are there?
Yeah, I am here.
Yeah, fine.
Rest all should be there.
Right.
Amish is there. Indranil is there. Suman is there. I saw her. Ashish, only I could not talk. Ashish.
Hi, sir, I'm here.
Hi, Ashish is there.
So when
So you have a full
Dr.
chance.
Sahu gave me this topic, no, I tried to see what are those landmark papers which were presented in ESMO and SABCS, and then I realized that actually, apart from the discussion on the keynote trial of Pembro chemo, actually there are no major path-breaking trials which we can discuss as landmark paper. So if I have to open this based on what Amish started his panel discussion, I will ask the question to Dr. Amish only. So what percentage of your patients of TNBC, early TNBC get Pembro plus chemo, sir?
Tarini would think 100% of them. But patients who can afford, I truly believe in Keynote 522 study and all the patients who are into inclusion criteria and all those who can
What percentage in your practice, if you see 100 patients of
I think around 50 to 60% of
50
patients.
to 60. And Dr. Suman?
100% there.
Obviously.
Sorry, I missed the question. I'm having some
What
problem with my
percent of your
video.
patients of neoadjuvant who get neoadjuvant therapy for triple negative breast cancers get Pembro plus chemo?
Oh, sir, did Dr. Amish sir say 100%?
Yeah.
I think it's nearly 100%. So I would agree with what sir said. Our center nearly 100%.
Oh, that's interesting. So I think then we should go to Ashish,
Prasad, you need to shift base again.
right?
Yeah, so I think we discussed with everybody, and we also believe that only the neoadjuvant component is the one which drives the majority of the benefit. And we also discussed the recent trial which Atul Batra presented from AIMS. So with all these, I think we're able to do it for say 50%.
And Dr. Indranil?
Yeah, 20 to 30%.
Fine. So I think
Wait,
this is
Dr.
good
Prasad,
actually.
Dr. Prasad.
Yes.
Just to Ashish, Atul Batra's paper was a low dose. So you
Right,
have
right,
started
right.
practicing that in
No,
your
no,
practice?
we will not go into that.
We will not go into
We have
that.
to
Okay.
discuss certain things.
Okay, it is
So,
moderator's prerogative.
yeah, yeah.
Sorry. We can chat.
So for all practical purposes now, for this panel, all the patients, because I have nothing else to discuss, all the patients will get neoadjuvant chemo plus pembro. Okay, then from there only we are going to discuss the
Excellent.
data. So from SABCS, I will just go through. These are all from abstracts actually. So I have read some of them in detail because they were all in one PDF format. From where I realized that from SABCS they have looked at some baseline biomarkers. They have found out signatures, pro-inflammatory signatures, pro-immune signatures. There is no need to go into details of them because they are all not in large trials. They are all just thought and then some data to say that we can predict. And also from the gut microbiome composition, which also predicts paths here. So let us ask Dr. Ashish, do you believe that gut microbiome composition will become a tool with which we will change treatment for triple negative breast cancer sometime in your life?
Yeah, I mean, I think from whatever existing literature we have, and also there are some clinical studies also, I think in renal cell cancer and in lung cancer, where they have figured out that one can actually be walking around with a good microbiome or a bad microbiome based on I think there's a species called Akkermansia and all which are associated with favorable response. And but the problem now is that how do we find out and
Right.
what
We will come to that. So
yeah,
then other
definitely we still don't know what drives anti-tumor immunity, and gut microbiome is very important.
So Dr. Sahu, if some patients come and discuss with you about gut microbiome?
थेरेपी डिस्कस कर ले वही बड़ी बात
ठीक है. So next, there are some data based on the treatment dynamics, like how to change the treatment, how the CD39 plus cell or CD38 cell monitoring, or getting a PBMC profiling, or there are new scores, PRP score, EA score. So this is all, and machine learning. Also the post NAB, this is something very important. I think this is something, there were a lot of data in SABCS actually, and from ESMO as well, where the RCB classes of 1, 2, 3, and then putting it against the molecular classification or the immune composition and trying to escalate. So this one trial I was very much interested in. Probably I can pick some brains on that. This trial actually did not give immunochemo in the control arm, but the patients who did not get a PAT-CR, they were given cryoablation plus IPI and NIVO in residual disease were with an EFS difference of almost 10%. So let us ask Indranil, have you gone through this study, or are you interested in such a study? And what is your take on this cryoablation?
Well, unfortunately, I couldn't go into that detailed study. This cryoablation of what exactly?
But once there is residual disease, there will be a cryoablation of that part, and then along
No, that part is removed. So they
yeah,
ablate
no,
what?
on the whatever is rest, I don't know exactly what is the mechanism, but
Yeah, that is what I'm
cryoablation
saying.
therapy. Yeah,
That we need to know what they're ablating.
but Amish sir, you want to comment on this?
See, in 2022, I think this was the first time some noise about cryo Nivo EP was there.
Right.
So 22 to 25, I don't think still it has made the headlines. So this is something which never caught my attention. But since you had sent me the slides, I was reading about that.
Right.
And I was seeing. So it was there in 2022 also. Again, phase 2 data. So I think we should wait for some more data before we can, talk about it, Prasad.
Sure. Dr. Suman, you were saying something. You were the only person who replied to my mail yesterday saying thanks. So I think I'll ask you, maybe you have searched that trial.
I did actually, even I had not come across this before. After I saw this, I came across it. It's interesting how they're trying to make a cold thing into a hot thing and then basically making it more immunogenic and responsive. So I think the data is very, I mean, it's too early to say anything regarding the data, but it is an interesting concept. Basically, that is the whole concept of immunotherapy in any of the tumors. You try to convert a cold tumor into a hot tumor and make it more immunogenic, and that's how it is more responsive to immunotherapy. So I think that's what it is.
Right. So Ashish, you are doing lot of low dose immunotherapy. So do you think a cryo plus a low dose immunotherapy in no path CR, such a kind of trial will have some scope in India?
So again, I have not seen the full text or the methodology exactly they followed, but I'm just guessing that they gave chemotherapy, and if they confirmed residual disease, they would have given some cryotherapy and given some EP Nivo.
Absolutely.
Now this
That is the point.
benefit is due to EP Nivo alone. What is cryo adding to it? Very difficult to make sense of a single arm trial like this, unless you have a random. But then, I mean, whether this changing the temperature of the tumor microenvironment, how does it affect T cells and Tregs and all that? That is something which we will probably. I mean, I haven't read this paper, so I really don't know.
Fine. So we will move on. We will go.
Capecitabine was allowed, in this paper, Prasad.
It was allowed. It was allowed. If this
Right.
is one this is not, yeah. Capecitabine. I'm not sure, sir. I don't know whether the escalation to capecitabine. I don't think it was there.
Interesting is that once they did all these, what proportion did have PATCR after all this?
No, they did not do anything different. No, the neoadjuvant was common for both. So whoever did not get PATCR, they escalated by adding cryo plus nivo on one arm, and the other arm received the standard treatment.
Okay, and so then they would have done surgery for this cryo plus nivo EP. So how many of them had PATCR because of this intervention? Anyway, it's an interesting study.
Yeah, we will see. Right. So we will move to ESMO. So ESMO actually has got some real industry-driven data on ctDNA, right? Signetra, Guardant Reveal. There is data that 70 to 90% sensitivity for recurrence detection, and many companies are now promoting this also. And the MRD positivity predicts recurrence 6 months or 5 to 12 months before radiologic evidence. That is the thing. And post NACT ctDNA status actually is there are studies which are even saying that they can ride over the RCB2 classification. With this, also some residual immune features which were looked at the tertiary lymphoid structures and all this. So with this, let us have some case. These are all, none of these cases are real. I just wanted to ask you, what do you think will happen, or if if there is a real world scenario where some patients do this test and come to you, what will you do? So we'll take one 38-year-old lady, germline BRCA mutation, PDL1 CPS 20, high TILs and inflamed TME signature. You should not ask me how I got this inflamed TME signature. It's just like that. From whatever is being discussed in the SABCS and ESMO, we will get this signature and we treat the patient with the standard therapy. So this patient gets everything good. PAT-CR, which we do always, ctDNA negative, and residual TME shows that the immune inflamed residual microenvironment, very good favorable feature in the PATH response as well. So let us start with Dr. Amish. So you have seen varied data, you have seen so many trials, and we heard Ashish saying that I would want to give the neoadjuvant component of the immunotherapy. So if you get everything negative, do you de-escalate this? If somebody comes and asks you, what do you think? Will de-escalation happen?
I would love to de-escalate, not because of this, but if these things are there, markers, and if there is even the slightest of IRAE which is hinting towards morbidity, I would explain to patient. But right now, just based on this data, I will not stop pembrolizumab.
But do you foresee a situation where we'll be de-escalating based on this data?
I think so, yes.
Because we will not get a randomized control trial for that.
No, definitely. See, for example, the second question what you have put, Olympia study did mention that if there is no residual disease, you don't need to give olaparib.
Right.
So
Right.
this is something like that only.
So Ashish, you said about your predominantly you prefer the neoadjuvant part. So what do you do in the adjuvant setting? Do you de-escalate based on PAT-CR?
So in India, I mean, that ultimately, I mean, we know it's a prognostic marker, whether there's a PAT-CR or no PAT-CR. And we also know that patients who have not had PAT-CR and they have continued Pembro, they probably have slightly better than somebody who has not received any Pembro at all, similar patient. But again, these kind of analysis does not answer the question, which component is driving this benefit? Is it the neoadjuvant component or the adjuvant component? And such studies, pharma company will never do it, but we don't know if there is any other body which is interested in doing such kind of a study. So, of course, in patients with PAT-CR and someone who is struggling to continue the therapy or having severe toxicity, I'll be much happy stopping it. Someone who's not had PAT-CR, we will add a capecitabine or olaparib and continue IO if they can afford.
Dr. Sahu, since you are the best person who predicts everything in oncology scenario and otherwise also, do you think that we will reach a situation of de-escalation?
People have started de-escalating without level 1 evidence being there. All of us believe that it does not add much. That's for sure. Or I think no pharma is going to sponsor a trial to de-escalate a drug. Indranil may add something, his hands is up, but I don't think so. But Mish's answer is the most practical.
Right.
That we would love to do it. We love to de-escalate, but because of the scenario and the micro environment which we are living on, the legal issues, we are really scared of doing it.
Sure.
Also,
I can't see the hand actually because I am seeing only myself.
Indranil hand is up.
Yeah. So de-escalation trials are already on. Those who are having PAT-CR, people have started de-escalation trials for them. That stopping.
In what scenario?
Yeah, suppose you have given Pembro plus chemo and the patient achieves PAT-CR, then to shorten the duration of Pembro. The trials are already ongoing. So now,
So we'll wait for the results.
Sure.
Yeah, so we should remember that in those who have got PAT-CR, the OS advantage of Pembro is only 0.7%.
Right. Fine.
So the fact that they have achieved the PAT-CR means they are having a good response. So we cannot differentiate.
We can hope that this maybe a ctDNA negativity or some kind of a tumor microenvironment data will help us take that decision in near future, and we may have a panel discussion next year.
And also just to add to this, we also have seen in negative results from the Atizo trial, where it was only patients with residual disease were included.
Right.
And also there is a very similar trial done with Pembro, which we have not seen the data. Of course, if the data is not out, then of course we all can assume it's a negative trial. So if the IO was active in patients with residual disease, then these trials should have shown some signal, which we have not seen.
Okay, so we will go to another hypothetical case with a discordant. Both the next two cases are discordant actually. So 55-year-old lady, cold tumor from the profile that we get, and PDL1 is also 0. So Dr. Suman, do you give this patient comes to you, will you give anthracycline, taxane, Pembro to this patient?
If the PDL1 is 0, this is neoadjuvant setting. You're saying neoadjuvant setting.
Yes.
I think neoadjuvant setting, irrespective of whatever, I mean, as of now, today, irrespective of whatever it is, the molecular signature, I would give immunotherapy to the patient because it is definitely better than just chemotherapy alone, as per the keynote 522. Now, moving forward in the future, would I treated differently. I think that there has to be clinical trials based on looking at TILs, high TILs. We know that respond better to immunotherapy. PD-L1 higher percentage, obviously the response even in 522 was better. The PD-L1 higher had a better response to the immunotherapy. So as of today, I will offer immunotherapy with chemotherapy.
In the urgent settings, and we gave immunotherapy because I told all the patients I have put as getting immunotherapy. So this patient gets a PAT CR, but ctDNA remains positive. These are all hypothetical, and you all know that we don't have any such data to discuss anything on this. But doctor, I will come to Dr. Indranil. If this patient comes to you, they do a commercially available ctDNA test after getting PAT CR. What do you do with that?
So patient is ctDNA positive.
Yes.
Even though the patient is having a PAT CR.
Yes.
Yeah. So as of now, we are not basing our decisions on the ctDNA, but in future, I think these patients should go on for escalation of therapy.
So you will not give capecitabine based on a ctDNA positivity?
No.
Okay, Dr. Amish?
As of now, no. But it is a very strong point for going for it.
It's a strong point you are saying.
Yeah, as of now, we are not able to do that practice, but in the future, it will definitely come because these patients are having a very high risk of recurrence.
So why not just give? Dr. Amish, would you give the patient does the ctDNA test and comes to you?
So I would serially monitor ctDNA right now, Prasad. If the patient is in PAT CR, I don't have any luxury to give capecitabine, but I'm a big believer of ctDNA. And as I was presenting in Fur Guide, I'm sure very soon we will have that you escalate your data on ctDNA. We have seen it in colon also. Now we have a 5-year follow-up data based on ctDNA, but we don't have in breast and TNBC right now.
But you will never get that study, no? Do you think some company will do a study with ctDNA?
Yes, of course. If it has been done in colon, if it is done in HER2 positive breast, why won't it be done in TNBC? I'm sure it will be done.
So, Dr. Sahu, do you think a study will be done whether ctDNA and then escalating to capecitabine?
It will be. I feel that's where we're moving. But most important is, was I always speaking Ramesh thing also, what ctDNA will matter. And if you have not done the ctDNA in the baseline, if a patient just walks in with a ctDNA report, I don't know what to do of it. And all of these follow-up studies are tumor-informed ctDNA. Till you are having this approach, your ctDNA report has no meaning. That's my take on how the ctDNA scenario will evolve. So basically, if you want to do ctDNA monitoring, it has to be planned well before you start your treatment. That is my thinking. Others who do or have a different thought can pitch in.
Anybody wants to pitch in?
I have a difference of opinion than Tarini here. One, Tarini, ctDNA without the baseline ctDNA I don't think you need baseline ctDNA. You're not going to compare MAF and VAF here. All the trials, they say ctDNA clearance or not clearance. So I think if the ctDNA is negative, then the baseline matters. But if the ctDNA is positive, it remains positive. And tumor
Exactly,
informed,
are you looking at in the
tumor
DNA?
informed, Tarini, you remember we discussed tumor informed is better because it gives a narrow objective answer. But if you have a tumor agnostic and if you know how to interpret those tumor agnostics, still I think it will be good.
Fine, we will come to tumor informed versus agnostic in one slide. So just flip this scenario. If the patient doesn't have a PAT CR and the ctDNA is negative, does that influence your decision in any way? Anybody? Indranil?
No, not ctDNA, but rather I would look at the TIL and the Ki-67 in that scenario.
And
now data is there that low Ki-67 and high TILs in those patients are having a very diagnosis, irrespective of further therapy.
no, your voice was low in this. I couldn't get it. So if there are no TILs, what will you do in that?
Yeah, if there are, high TILs and
Yeah.
low Ki-67,
Yeah.
then there is a case for not escalating, even though there
Right.
it may be RCB1 or 2.
Okay.
Yeah.
Anybody wants to comment on this statement? Dr. Suman?
RCB2 is already an intermediate risk. I think it's a risk factor already. And there is no clinical trial to say if an RCB2 was there and then you had a TIL positive, they do better or worse. We assume that they will respond better to immunotherapy if their TIL is present. But I think I would stick to prognosticating. I would stick to the RCB2 being a prognostic factor for outcomes, the Ki-67. And I wouldn't, at this point of time, I think I wouldn't de-escalate or escalate based on ctDNA in an
Sure.
RCB2
So I
patient.
think we have reached our time of 9:15 this last session. So I will just so my takeaways after reading through some abstracts for this, I thank Dr. Sahu for making me read this actually. So I would not have read any of this. Is that there is definite some clear data which is coming about immunotherapy selection actually based on TMI profiling, and we may be able to select more patients more than the PDL1 based, and now we are not selecting even based on PDL1. And the ctDNA guided adjuvant therapy, I think, will come. We can sit and discuss at length whether we will be changing or not, but a ctDNA negativity might be overruling many of the other things which we say are traditional risk factors for, because we all see those patients who don't get a PAT-CR but do really well, and vice versa in our practice. And so composite risk assessment beyond PCR is going to be there, and we will have to live with this, and we will not have any phase 3 data to base our decision making, and we will all evolve and do our own thing in this. So microbiome, this is something very interesting actually. We will see whether patients will come, and when patients ask nowadays it's very difficult to say eat whatever you want. So definitely that is going to change. Though Dr. Sahu says that they don't ask any such questions, but most of us get all patients who ask and who come and ask us so many things about gut microbiome and what to eat and what not to eat. So practical implications, maybe in Amish's practice, all the patients will get neoadjuvant Pembrose and also get a PCR.
सुमन की प्रैक्टिस में मेरी
सुमन की
प्रैक्टिस
प्रैक्टिस
में
में no,
50%
अमीश के
please
प्रैक्टिस में
remember
only treatment.
that.
सुमन के
No,
प्रैक्टिस
and
में MRD, and then for
ctDNA.
Ashish there is a ctDNA spatial immune profiling microbiome.
Also, Dr. Prasad, because I just want to add here because for the audience that many times it's what we do in our unknowingly we alter the gut microbiome, like the rampant use of antibiotics, rampant
Right.
use of proton pump inhibitors.
Right.
So it's just not about what the patient is eating or where the patient is living. It's about what drugs is he on, and that is something which there's a lot of data out there but many of us are not aware.
Sure.
Just can I ask you something? In your patients, most of them, I think so, will receive the low dose immunotherapy. And AIMS data does tell us the PAT-CR looks similar. So if the patient does not achieve PAT-CR, do you add capecitabine to your adjuvant part along with the low dose immuno?
Yes, sir. So in that situation, I will say capecitabine is more important drug than whatever else you're doing.
So you combine the capecitabine with immuno.
Yeah, I mean, immuno if he wants to continue, yes, and capecitabine definitely.
So Ashish and Natarini, I know we are in the last fag, but I have slight difference here, Ashish. If we have the rectal trials have taught us that 6 to 8 months of immunotherapy is more important because the ctDNA clearance happens after 3 months, 4 months, 5 months also. So what I'm trying to say is that when you say capecitabine is more important than IO, may or may not be correct. IO may work little later as if you see Keynote 522 post PAT-CR, the hazard ratio, although we should not take a separate differential, was different as compared to those who did not achieve PAT-CR. In fact, the immunotherapy worked better there. So I would say is that pembrolizumab, when patients who have not achieved PAT-CR, along with capecitabine, both are extremely important.
And if it's
But
BRCA
low dose
positive, how do
pembro
you do it? Chirag sir has a question.
BRCA positive,
Residual
they have
tumor,
shown very nicely, na Tarini, that
residual tumor with 522 is BRCA positive.
I would add olaparib for sure.
One after the other, no, sir.
IO एक साल उसके बाद olaparib,
के बाद
that is
होला.
how you are saying. See, olaparib could have been started. I'm not sure between hormone and olaparib, one after another could have been started at least up to 16 months after the other.
That's fine.
So
I'm talking about triple negative.
yeah, no. I'm just saying, extrapolating that, we can start sequential, Suman, but I would like to start continue Pembro and add capecitabine there. So, madam, this is what I would do, but I will explain to patient for sure. And IO
Typically,
plus
you will add capecitabine in the
Oral.
first 4 to 6 months, and then add olaparib after
then
that, and
olaparib.
continue.
That is what I was
Dr.
trying to
Sahu,
say.
I think
Thanks, Tarini, for
we should ask tell Chirag sir to come and say
Yeah,
something.
and
But,
we have to get the link to him next
oh,
tomorrow.
that
I'm
is
going to
fine.
send
So he has put a
link.
line called gut microbiome will convert people to tools actually. So
That is fine. That is Chirag sir. But the other two questions are important.
right.
So Chirag sir, no one told capecitabine is Ola definitely. They told sequence it. That's what Amish told. Immuno to continue, complete it, and then probably add capecitabine in the first half and then Ola in second. That's what Dr. Amish spoke. And
Yes,
Suman,
absolutely.
you wanted to sequence the whole scenario. First finish the immuno, then Ola. That's what you told. Okay.
Yes, yes.
Okay.
Fine.
So
So I will
I
close
will.
the session and I'll hand it over to Dr. Sahu. Thanks for a lively discussion at this point of time. And Dr. Amish, please go home.
Sorry,
Tarini,
Prasad, that was we had very little to discuss. My last word about 522. Someday I would like to put a Sandil and speak about the Kaplan-Meier survival curve of 522. And I would like Amish and everyone today refresh the memory of Kaplan-Meier. Let's go back. We are
Restricted mean
speaking.
survival time of 19 days. I remember, Tarini,
So,
your
so my
sentence.
point is we have been going around the town with the 522 data, and I want to exactly read everyone to read that one paragraph of NEGM and the RMST curves, and the difference only 1 month. And if you are looking at that, I am I have my own reservations. I'm not sure. And the curve separates after a long 12 to 15 months. It's not a short time. So with that, I will just like to end. Thank all the faculties. Thank all the attendees. We reached 140 and it was a busy day of lot of live webinars, and still I was very happy. And Sendil, not to take away others who did an excellent job, is always the showstopper, and that's what he did even today. And we will have tomorrow, day 2, and the best we have saved it to the last. And those of us who have heard Sendil, we would like to see him speak the best 4 to 5 abstracts, what he feels in ESMO and SABC, which can change practice. Till then, good night, stay safe, and let's meet each other next week or maybe next week after and discuss 522 someday with Amish live someday. Thank you.
Tarini,
Thanks,
first of
thanks.
all, congratulations to you for putting up such a wonderful show year after year. Single-handedly, what you do, of course, you have a team, but I think even last year I was highly impressed, and today also, I am enjoying. Hopefully tomorrow some conflict is there, but I would like to join as soon as possible for at least the second showstopper of tomorrow, Senthil's talk.
Thank you. Thank you, everyone. Thank you, everyone.
Thank you.
So thank you so much, Dr. Sahu, from all of us, my colleagues, Daud and Aditya. Good night, and we see you tomorrow again, sharp by 7 p.m. So thank you, support team. Thank you, everyone. Please close for the day. Thank you. Thank you. Thank you, Daud. Thanks, Aditya. Thank you, Sahu, sir. Good night.